Welcome, everyone. Good morning and welcome. This is day 3 of the NIH P2P workshop on identifying risks and interventions to optimize postpartum health. We're glad you're here with us today. Welcome back to those who have been with us the past 2 days, and welcome to our new attendees for today. Just a couple of notes to get us started. Today, we'll continue discussing key question 2, which we will review with you in a minute if you weren't with us yesterday. And we'll have our final roundtable discussion today. Today's roundtable is on cardiovascular risks and interventions. We will also have a closing keynote presentation by Dr. Alan Tita at the end of today. So before we turn this over to Dr. Corinna Davidson, our panel chair, I'll briefly share some housekeeping items. These are redundant from the past 2 days for those of you who have been with us, but I know we have new attendees today, so I want to make sure we go through them quickly. So next slide, please, Catherine. Okay, so you can find all of the information here on this slide on our workshop webpage, which is listed at the bottom. So the final agenda, bios for our panelists and speakers, the draft systematic evidence review, which is now available for public comment through December 4th. So we strongly encourage everyone who's attending today to review that if you haven't already and provide comments. And also at this webpage, the panelist draft report and workshop proceedings in early January. Next slide, please. So just a reminder to everybody about the Office of Disease Prevention event guidelines. I won't review all of the bullets on this slide, but encourage you to read them in full on the ODP website. We do ask attendees to follow these guidelines. ODP strongly feels that it's important to uphold the professional and educational purposes of our meetings by respecting the rights and views and privacy, safety, and dignity of all people who are attending or not attending, which means exercising professionalism, consideration, and respect in all of your actions, including those that you put in the chat, and refraining from behavior that is harassing or inappropriate. We appreciate you understanding that. Next slide, please. Okay, so how to comment and ask questions, which we really encourage all of our attendees to do. Use the WebEx chat pod and send comments to everyone, or send the NIH P2P team an email, or join our conversation on Twitter. Next slide, please. If you do have any technical difficulties, send a comment in the chat pod to all panelists, and then all of our staff in the background will assist you, or send an email to NIH P2P. Next slide. If you need to access the closed captions, take a look at the 3 dots down at the bottom of far right bottom of your WebEx screen, and then open the multimedia viewer. Next slide. Okay, zooming in on content, WebEx makes this really difficult, but you can do it individually on your own screen with the plus or minus buttons at the very top of your WebEx window underneath those thumbnail sketches. And next slide. Okay, opportunities to comment beyond today. Like I mentioned, we encourage everybody to review and comment on the draft systematic evidence review that was prepared specifically for this workshop by the Minnesota Evidence-Based Practice Center. And you will hear a presentation from them today. And then in the next couple of months, we also strongly encourage you to review and comment on the independent panel's draft report. The report will summarize the workshop proceedings and provide recommendations for future research priorities, and it will be available in early 23. Next slide, please. Okay, we have a post-workshop survey that we send out to all attendees. The survey will be posted in the chat, and you'll receive an email at the end of the day today. It is different for each day, so please, if you've attended other days, please also complete today's. It should only take you a couple of minutes, and ODP actually does really read through all of the comments that we get and change the program accordingly. So we appreciate your feedback. Next slide. I think that might be it. Okay, I will now turn, okay, thank you. I will now turn the workshop over to Dr. Corinna Davidson for an overview of the past 2 days.
Thank you so much, Kate, and thank you everyone for joining us. I'd like to specifically thank Office of Disease Prevention for leading this important topic. I'm Karina Davidson. I'm the chair of the independent panel that will be writing up the interesting key points from this workshop, as well as from the evidence-based review, for which we will hear some more today. I welcome all of your comments and questions. I will first be asking independent panel members for their questions and comments, and then I'll be turning to the questions that you've posed in the chat. So let's look forward to a very intellectually engaging and important day today as we round to day 3. And I'd like to turn it back to Kate to introduce our next speaker.
Thank you, Dr. Davidson. I'm so pleased to now introduce Dr. Eliseo Perez-Dabal, who is the Director of the National Institute on Minority Health and Health Disparities at NIH. He will give our opening remarks for today. NIMHD conducts and supports research programs to advance knowledge and understanding of health disparities, identify mechanisms to improve minority health and reduce health disparities, and develop effective interventions to reduce health disparities in community and clinical settings. Since joining NIMHD in September 25, Dr. Perez-Dabal has been cultivating the Institute's position on the cutting edge of the science of minority health and health disparities. Through this effort, the Institute has produced a collection of resources and guides that facilitates the conduct of research to promote health equity. You can find more information on Dr. Perez-Dabal and the NIMHD in the link in the chat, and we are just so pleased to have you here with us today. Thank you.
So good morning, everyone, and welcome to this day 3 of this really important P2P workshop. It is a long time in developing. So NIMHD has been a part of the effort at NIH to address the disproportionate burden of severe maternal morbidity and mortality amongst populations with health disparities. From the beginning, we'll follow the lead of our sister institutes in child health and in nursing and the Office of Research on Women's Health in this effort, and there will be a lot more coming from this in the future. We're also partnered with National Heart, Lung, Blood Institute on these issues, and we have actually since 2020 been active in this space and have been receiving R01 grants on maternal health since then, so keep them coming. Next slide.
I was told you were going to be advancing, but I'm happy to do it for you.
Well, I didn't share, so I don't think I can advance.
Actually,
I
there
can,
you
yes,
go.
okay.
Yes.
All right, thank you. So I want to start by identifying what important factors race, ethnicity, and socioeconomic status bring to the table. These are race and ethnicity as a social construct and socioeconomic status as a measured aspect of social class. And in all research, in all clinical care of people, these should be measured in a standardized way and considered as influential or possibly influential in the health processes and outcomes that we are working with. There's many lines of evidence to support this approach. If you look at severe maternal morbidity and mortality, the topic of this workshop, we don't really fully understand why this takes place. We look at some conditions like asthma disproportionately affect African Americans and, for example, Puerto Rican individuals, but, for example, not Mexican Americans. We know that most chronic diseases are more common in people who are poor of any color, and it is not due to bad behavior. There's a lot of structural factors that influence that. And even within a diagnosis of type 2 diabetes, within the healthcare system in Northern California, Kaiser, all minority groups studied in that registry had 30% less heart disease and twice as much end-stage renal disease compared to the white individuals with diabetes. So what can science do to reduce inequities generally? I think we need to start with basic things done well. So standardized measurement of these factors that affect health need to become part of the scientific culture in those who work in minority health disparities. And NIMHD is 100% behind that. We also need to expand our capacity and training in big data, in discovery as a discovery science tool. We need data scientists to focus on this. Without the expected biases that have existed in many of the data sets that are currently available. And this goes beyond electronic health records. It includes population records as well. We also need to be an engine for promoting diversity in the workforce. We are at a crisis tipping point. 14% of medical school graduates and the newly minted PhDs in the STEMs, broadly defined from the US, are from underrepresented racial and ethnic groups. And we make up about a third of the United States population. This has to decrease. This gap needs to decrease. The pipeline is not empty, but our graduates are not necessarily being hired. We need to use community engagement as a research platform. It's not just being nice or giving back to the community or bringing them on board after you've decided what to do. We really need to build trust over time for sustainable relationships with our communities. And then lastly, we need to implement what we know. It's really embarrassing sometimes to see that we know how to do something, treat hypertension or control diabetes, and we do worse in populations who are most affected. And these are data derived from population studies. So this is really another priority. Now, back in 2019, NIMHD embarked on a project that we call our Social Determinants of Health Phoenix Toolkit project. It was with the goal of creating a resource at NIH through the Phoenix Toolkit website for measures that we would vet with the community and encourage our scientific community to use. It's in every funding opportunity announcement that NIMHD has now. It is up and running. We went through an initial process. It actually got launched in May of 2020. It includes basic demographic measures as well as measures of socioeconomic status, et cetera, that were already on the website, but we collected them and vetted them, as well as other individual measures of social determinants of health and population measures. We are in the process of completing our second round of reviews done by an external scientific committee, and we are considering how we're going to manage this going forward. I encourage all scientists who are considering applying for grants to really look at this, both for the individual factors that are listed here, as well as the structural determinants of health, without dwelling into those specifics. I want to also highlight, although based on what I was able to see of the workshop the last 2 days, this topic has been front and center in this workshop, the importance of racism in dealing with health outcomes that lead to disparity, that are reflective of disparities. These are data that are now 8 years old. They come from the Kaiser Family Foundation surveys, and asked Americans, a representative sample of Americans, in the past 30 days, have you been treated unfairly because of race or ethnic background? And you can see the results there. Over a third of Latinos say yes. In the last 30 days, over half of African Americans say yes in the last 30 days. And clearly, you don't need a p-value to know that it's much higher than it is for white Americans responding. They didn't have sample size for other groups, so if you're wondering. So I think that we have a problem, and not to overemphasize what has already been discussed. We need to address it. We need to talk about it. We need to figure out what are we going to do about this, rather than assume, oh, it's not polite to talk about racism because I'm not a racist. How can I possibly be worried about this? And really focus on solutions and on mitigation strategies for these issues. We heard some about structural racism as well. And this is a topic of interest to us. There were 38 R01s funded by NIH in the last fiscal year on structural racism. This was an initiative led by NIMHD, but endorsed by almost every institute and center at NIH. This is an example of work done by one of our prior investigators, Elizabeth Howell, looking at adjusted severe maternal morbidity rates for Black and white deliveries in New York City hospitals. And the striking point here is that if you look at low Black serving hospitals, the rate for severe maternal morbidity for Black women was lower than the rate for white women in high Black serving hospitals. So this is telling me it's not about the color of your skin or your race or ethnicity necessarily, but it's really about the structural organizational factors in these two different types of hospitals. And this is the kind of research questions that we need to generate and probe and intervene on to decrease these disparities. This is a great example of implementing what we know. In New England Journal of Medicine article earlier this year, treatment of mild chronic hypertension, not preeclamptic symptoms or elevated blood pressure, but pregnant women with known mild hypertension, so-called mild hypertension. You can see the diversity of the sample, active treatment group versus a comparison group that would not be a control group that would not be treated unless the blood pressure went higher. And you can see the composite outcome difference, absolute difference of almost 7% improvement in preventing progression to severe preeclampsia, preterm birth, or placental or fetal or neonatal death. So I think you have a sense here that this is something we ought to be very proactive about. And who has more mild chronic hypertension when pregnant? African American women. Latino women have the same as white women. So we really need to focus on these groups, on this condition, and treat it aggressively. This is a publication from one of our grantees on the environmental disparities research centers, associating ambient air pollution with maternal depression. This is a cohort study in Southern California, predominantly of Latina Hispanic women in the Los Angeles area. And you can see greater exposure to ozone, to nitrogen dioxide or PM2.5 particles was associated with postpartum depression. And I don't need necessarily to emphasize how critical mental health issues are after delivery, as well as during pregnancy. And I think the importance of that and addressing them, asking about it, diagnosing it, and managing it become critical, whether or not this is a mechanistic issue related to this. This is one of our early stage investigators from several years ago, looking at a study of what happens with prenatal care expansion of Medicaid. Now, you're aware women who get hospitalized, who are pregnant, who are uninsured and undocumented as well, receive emergency Medicaid. This ends 6 weeks after delivery. And we now well know that issues and complications, and in fact, a third of severe comorbidity occurs in the postpartum period. And in this study, comparing linked Medicaid claims and birth certificate data between Oregon, which does extend coverage, and South Carolina, which does not, we saw better control of the women with diabetes by increased use of anti-diabetic medication, increased use of insulin. So in evidence that increasing coverage will help overall, we think, but especially in women with a chronic condition. So in ending this talk, I'll share my own biases or my own thoughts on where I think we ought to be emphasizing in the near future. First is access to healthcare really matters. Of course, it's not just access, it's quality, and you need not just the insurance, but a place and a person, and extending or guaranteeing coverage at least for a year after delivery is critical for all women who deliver, including the undocumented, which is, I think, an important policy issue to be made currently mostly at the state level. Second point is the importance of coordination of care, particularly for women with a chronic underlying condition. Now, many women will be healthy, will be fine, and you say, well, does healthcare really contribute a lot? Probably not much. And you say, well, they don't come for a follow-up visit or maybe just one visit. Even telemedicine will be sufficient. But there are many women with chronic conditions, more so today, who do need coordination of care. I would advocate for a primary care focus, either from family medicine or general internal medicine, many who are specialized in women's health, coordinating with the subspecialists who may need to be involved in this care. We need to ask and address about mental health, substance use, and interpersonal violence. Women who have delivered are murdered at a disproportionate rate or are victims of violence. And then there's often involvement of substance use or issues of complication of underlying mental health issues. These are important. I already mentioned the issue of engaging communities, and we need to engage community resources to promote health. How do we access healthy food and green space? And then combined with this is outreach staff, whether it be home visits, proactive outreach, not allowed so the patient to say, well, I'll need an appointment, but really proactive check-ins, sort of the idea of population-based care, that you know that these particular number of people will have increased risk of something happening, and sometimes a quick check-in will avoid a crisis. That's it for my presentation. Thank you for your attention, and I look forward to the rest of the time I'm able to stay with you.
Thank you so much, Dr. Prestable. We really appreciate you joining us today, and also appreciate your staff who have helped to plan this workshop over the past couple of years. We will now continue discussion for today, starting with key question 2, which is immediately before or immediately after delivery and before release from birthing-related care, what combinations of risk indicators to the birthing person have the greatest effects on poor postpartum health outcomes? So just want to make sure everybody is aware of key question 2, and we'll start with our EPC presentation. So I want to welcome Dr. Mary Butler from the University of Minnesota Evidence-Based Practice Center, and she will present on social and structural determinants of maternal morbidity and mortality. Welcome, Mary.
Yes, good morning, everyone. I'm really happy to be here today to represent the team that has been brought together to present this material to you. Next slide, please. Just as our regular disclaimer that we, as a team, don't have any particular conflicts of interest to report, and that we acted as independent investigators in this process. Next slide. We had a really large team of some very excited and interested people, and want to highlight the transdisciplinary nature and the many areas of expertise that were brought to the team. Next slide. As so many people have talked about, maternal morbidity and mortality rates are increasing. This is not a good thing. With this increasing attention on social determinants of health, we're hoping that this can help contribute to changing the narrative of individual risk and not placing the blame on the pregnant and birthing person. And today we'll be presenting the third of 3 presentations of the results for this report. Next slide. To give a sense of how we approached aggregating the material here, we were thinking about this from the standard sort of socio-ecological model that considers risk factors that can be generated anywhere from the individual level through networks of increasing societal contributions. Next slide, please. But we also want to think about this in terms of upstream and downstream. One of the contributing models, we did not use this as a particular model to present the results, but it informed very much the approach that we took to the review. Next slide, please. Excuse me. We also want to make sure that we take a moment to acknowledge the way that language has been changing over the years. The terms that have been used to label racialized and marginalized groups have really been shifting. It makes it challenging to aggregate across these terms. And likewise, medical diagnosis terminology has also been changing over the years. So in our presentation of the material, we have tried to use the same language that the study authors were presenting the results within, rather than trying to impose some other standard. Next slide, please. We also recognize that not everyone who gives birth identifies as a woman, and so we attempted in our report to really try to use gender neutral language. That being said, many of the studies, again, had their own language and terminology, and so we used study author language for consistency with the research. One place that we broke from that was in use of, when talking about racial discrimination, rather than using perceived discrimination, we were noting it instead as reported discrimination, acknowledging that that recognition perception is a necessary step in that stress appraisal process. Next slide, please. And moving into our methods, next slide. The two key questions that were addressed in the report, for key question 1, from a pregnant person's potential entry into prenatal care, what are the combinations of risk factors, and to what extent did these patterns vary by race and ethnicity? Next slide, please. Key question 2 really only changes the key question to incorporate instead people who are birthing people. So immediately before, during, or immediately after delivery, before release from the birthing center or hospital or other facility. Next slide, please. Excuse me. We used a PECO framework. For people who are familiar with systematic review, you're used to hearing PICO. The main difference is that instead of an intervention, we're looking at the exposures. And we looked specifically for studies that were using social and structural determinants of health as the exposures. Next slide, please. There were a wide number of population exposure outcome timing setting. The only main difference between the categories between the two were in the populations that were used. Otherwise, these were essentially the same. Next slide, please. We looked through Medline, CINAHL, and social sciences to pick up the social work side, and used search algorithms built on mesh terms and keywords. We did not put any restrictions on the publication dates, but we did include only English language, and also noting that it was US based, not non-US, right? Next slide, please. For our decision rules, we looked at only those studies that were truly examining social determinants of health as a primary or secondary factor of interest. If a social determinant of health was used purely as a control variable, those were excluded. Studies needed to measure pregnancy at 20 weeks of gestation or beyond to be included. And then we were really looking for studies that were looking for that kind of interpersonal factor as opposed to that intrapersonal. So for example, not just merely the presence of substance use, but the social stigma related to it. Next slide, please. We did examine the risk of bias initially from a stance of determining if any of the studies used a study design that was rigorous enough to actually address the question from a causal standpoint. And we did determine that all of the included studies were of high risk of bias from this causal standpoint. Therefore, we went forward in the process from the perspective of examining this literature to support future researchers in generating hypotheses for risk factors as the basis for potentially developing new interventions to address the challenges. Next slide, please. So we categorized the studies into their major social determinant of health exposure based on what was available in the literature, and have been presenting over the last 3 days with these factors somewhat grouped into the first day of a little more individual perspective, if you think back to that nested circles back in the introduction. The second day was more at the communal, community or societal level. Today, we're going to be focusing in more on that interpersonal space. And so we'll be looking at material from violence, trauma, and psychosocial factors. Next slide, please. We'll be presenting the material using the alluvial, or we're calling them braided river graphs. These graphs are used to try to show this interweaving of the variables that are presented. Next slide. We're just going to walk you through just a little bit so that for those of you that aren't familiar with these types of graphs, the outside columns are our groupings where we were categorizing them by the social determinant of health domain or the outcome domain. The internal columns are showing what were the actual terms that the study authors were using. And any one particular line relates to a study outcome. And so you can follow the lines between the domain, the determinant of health domain, and the outcome domain. Next slide, please. So for our results, next slide, please. We started out with over 8,000, almost 9,000 studies, references to screen through, and eventually winnowed it down to 109 included studies. Next slide, please. To give you an idea of the types of information that was contained in these studies, they came from a wide range of data sources, and the sample size were necessarily very wide in range as well, depending on the type of source that was used. Next slide, please. The studies generally were able to be categorized into a set of outcome domains. So here you'll see cost or health care use, cardiometabolic disorders, depression, diabetes, hypertensive disorders. Next slide, please. Maternal mortality, other mental health or substance use, not depression, severe maternal morbidity, and weathering or allostatic load. Next slide, please. Over the full literature set, we want to note that the included studies really covered a broad range of social structural determinants of health, but they still only represented a subset of what might be potentially worth studying. And that the literature itself did not address intersections between biological medical risks and the social determinants of health overall. There was very limited depth and in the quality of the available research within the material, including racism and other forms of discrimination. And we noted an unexpectedly large volume on violence and trauma relative to the other social determinants of health. And as far as the outcomes domain, depression in particular was a large proportion of the outcomes captured. Next slide, please. So moving into the particular factors, violence was found to be studied in a total of 16 studies in key question 1. And I want to note here that in these 3 factors did not actually show up in studies that would represent key question 2. They were only represented in studies that address key question 1 and the pregnant population. And I also want to be clear about the directionality of the violence factors because of some of the conversations in the previous days, that this would be containing research that looked at violence as the factor and the outcome on the pregnant person's maternal outcomes. What would not be, included in this set would be where pregnancy itself was the risk factor leading to violence as an outcome. So in that case, it would be the experience of violence and or homicide. Next slide, please. For trauma, we found a total of 6 studies that examined this, and that did include such things as a lifetime trauma, military, sexual trauma, etc. Next slide, please. And for psychosocial factors, we found a total of 10. And we'll note here that they were far more commonly incorporated, not examining psychosocial as the straight up, but as the as a factor that contributes. Next slide, please. So here's the alluvial graph that puts these 3 together. Please do note the messiness of this graph. And I'm going to go ahead and next slide, please. Next slide, please. This messiness is necessary. The more braided this river is, the more information we have to understand how interrelated these factors are, and that we really are trying to capture the complexity rather than reduce it. This is a very complex topic. Our groupings were subjective, so please note that other investigators could have approached this and grouped things in different ways, and that would be quite reasonable. Next slide, please. The review is limited in the sense, in particular, that we ended up needing to exclude many studies that looked at comorbidity and medical approaches because those were the cases where social determinants of health were used only as control factors. Because this was a super wide scope, we focused on the quantitative epidemiological studies, not the qualitative. And we, in including our studies into these discrete groups, it did require us, as I noted, to categorize subjectively. Next slide, please. So for future research, there's a lot that's needed. We really would recommend that the work move beyond the disciplinary silos and continue with the type of transdisciplinary approaches that we're seeing arising in the literature. There's a need for research that expands the domains of the social determinants of health, and also the mechanisms and the pathways by which these factors impact pregnant persons and birthing individuals. And this review represents only the cusp of social determinants of health and maternal health research to come. Next slide, please. The material organized in curated catalogs of maternal health exposures and their presumed mechanisms would really facilitate future examinations of the exposure. It would be wonderful if researchers could name the form of racism being examined, mechanisms by which it may work, and other intersecting factors that might compound its effect. And if we could improve the adherence to basic reporting standards, that would make it much easier to identify high-quality research and how it contributes to the body of the evidence. Next slide, please. Here is a link for the report. As noted, the public comment is available through December 4th, and we would love to hear your thoughts about the review. Next slide. And here's our contact information, should you also wish for that. Thank you.
Wonderful. Thank you so much, Dr. Butler, for taking the time to go through that, and also to your staff for working on this report the past year or so. Okay, now we will move on to a series of 4 presentations on key question 2, followed by a discussion session. And we will start with Dr. Katie Cosminiel and Julie Interrante. They will present on policy to improve postpartum health equity. Thank you.
Good morning, everyone. Thank you very much. My name is Julie Interrante, and again, I will be talking about policy to improve postpartum health and equity. So we don't have any conflicts of interest to disclose, and we want to acknowledge that where we are here in Minnesota is on the traditional ancestral territories of the Dakota Nations. We also want to thank the Federal Office of Rural Health Policy, who funds and supports all of our work here. So I'm going to start by describing disparities in severe maternal morbidity and mortality and in postpartum care content at the intersection of rurality, race and ethnicity, and health insurance. Then I'll examine communities most impacted by limited access to obstetric care with implications for postpartum health. Then I'll be turning it over to Dr. Cosminiel to highlight current policies aimed at improving racial and geographic equity in postpartum health and care. So as it's been discussed here already, maternal mortality has been rising in the US, and there are well-known, well-published inequities. Risk for maternal morbidity and mortality is unevenly distributed, with some of the populations bearing substantially greater risks, and risk may be compounded at the intersection of these factors. So I'm going to be presenting some results from our study on severe maternal morbidity and mortality during childbirth hospitalizations at the intersection of these factors. So across intersectional categories of insurance type by rural and urban residents and by race and ethnicity, after adjusting for sociodemographic and clinical risks, 4 of the top 10 highest incidents of severe maternal morbidity and mortality occurred among Black birthing people. Rural and urban Medicaid-funded births by Hispanic or Indigenous patients also had incidents among the top 10 highest. So we also examine additive risks of these factors, meaning whether insurance type interacted with race and ethnicity and rurality to increase the risk of morbidity above and beyond what would have happened if the individual risks were simply added together. These figures show the graphical example of our findings, the one on the left for rural Indigenous folks and on the right for urban Black folks. So the gray bars show baseline risks for severe maternal morbidity and mortality among white, urban, privately insured births. The lightest blue shows the additional risk related to Medicaid beneficiaries. Medium blue shows the additional risk related to race and rurality. And the dark blue shows the additional risk that is due to the additive interaction. Another way to interpret these findings is these results suggest that if excess risks associated with Medicaid could be mitigated, meaning that it could be reduced to the level among those that are privately insured, this would not only prevent the 23 cases per 10,000 births that occur among white urban residents, but an additional 98 cases per 10,000 births among Indigenous rural residents and 41 cases per 10,000 births among Black urban residents that occurred because of the interaction of these factors. So part of preventing poor maternal outcomes in the postpartum period involve improving postpartum care, as has been recommended by the American College of Obstetricians and Gynecologists and the World Health Organization. Recommended components of postpartum care include mood and emotional well-being, sexuality, contraceptive, birth spacing counseling, discussions around sleep and fatigue, physical recovery from birth, chronic disease management, and health maintenance. We analyzed self-reported survey data covering most states, and in these data, most patients reported attending a postpartum visit. Among those with a visit, depression screening and contraceptive counseling were very common, between 85 and 90% of respondents. These components are recommended in existing national quality standards, which are often tied to financial incentives for clinicians, healthcare facilities, and insurers. But other recommended components that are typically not specifically financially supported were only reported by 50 to 60% of patients, including smoking and abuse screening, birth spacing counseling, and discussions about healthy eating and exercise after childbirth. We showed that So among patients who attended a postpartum visit, we calculated risk-adjusted differences in receipt of recommended care. So for time, I'm just going to focus on the two components with existing national quality standards, so depression screening and contraceptive counseling. When insurance, geography, and race ethnicity were examined individually, receipt of these components was significantly lower for patients insured by Medicaid, for rural residents, and for people of racially minoritized groups. However, when these disparities were further disaggregated, a more complex picture emerged. For example, the lower receipt for Medicaid compared to privately insured patients was largely driven by urban white patients. And the direction of the care disparity across race and ethnicity was dependent on insurance type and rurality. Intersectional differences, which account for cumulative effects of having multiple disadvantaged or advantaged identities, were consistently much greater than any individual difference. So both maternal morbidity and mortality and postpartum care are greatly impacted by access to care, which is especially challenging in rural areas. Currently, 56% of rural counties have no obstetric care, and this comes after decades of hospital and obstetric unit closures in rural communities. Communities at highest risk of losing hospital-based obstetric services were those with a higher proportion of lower income or residents of color, were located in more remote rural areas, had smaller workforces, or were located in states with less generous Medicaid programs. As a result, many birthing people now have to drive long distances to give birth, have higher rates of preterm birth and out-of-hospital birth, and births in hospitals without obstetric units. Our research has also found that such losses are associated with lower access to maternity support services, including community and hospital-based breastfeeding and postpartum support groups. As I mentioned on the previous slide, there are racial and geographic disparities in access to obstetric services. And as you can see from this map, the South has the lowest density of rural hospitals with obstetric services available to patients who may need them. Of the 17 highly rural states, 29% have fewer than the median number of rural hospital-based obstetric services available. And of the 9 states with the most racially diverse rural populations, 78% had fewer than the median. So now that we've added the complicating dimension of rurality and geographic access to our discussion of inequities in maternal morbidity and mortality in postpartum care, it's time to look at what can be done about this. So I'm going to turn it over to my colleague, Dr. Katie Casamano, who will now highlight some of the current policies aimed at improving postpartum health and care by rurality and race.
Thanks to all of you for forward from talking about childbirth and postpartum care that Julia highlighted in research and the research we've done together, to talking about what can be done. What I'm going to do here is briefly describe a few recent policy interventions and discussions and go into a little bit of depth on the first topic here, digging into some evidence that we've recently published, looking at postpartum Medicaid extension, which I know has been a topic that's been discussed. What I specifically want to highlight, I don't think any of these policy initiatives are new to our discussion as part of this workshop, but I want to highlight the intersectional and equity aspects of their potential implementation, as well as the importance of conducting research and policy research that addresses intersectional identities and additive and cumulative risks that happen over time and across multiple identities for people. So the different policy initiatives that have been discussed and hold promise for improving equity in postpartum health and care are extending postpartum Medicaid coverage beyond 60 days postpartum. We're again starting to see emerging research on that topic. I want to highlight the Rural Moms Act, which is a piece of legislation that was passed in the past year that really focuses on workforce and training to increase access to maternal and pregnancy and postpartum related services in rural communities with attention to intersectional identities. Medicaid policies, in addition to just coverage extension, could focus on low volume payment adjustments and other financing mechanisms to focus on rural communities or other communities that have fewer patients, but that still require access to services to ensure the health of rural residents and others. There is a new designation of a type of facility called rural emergency hospitals that has just been released and is starting to be implemented in hospitals across the country. And there is a potential there for focusing on emergency obstetrics in rural settings and ensuring access to emergency obstetric services in communities across this country, as we do in international settings and in global public health all the time. CMS has recently created a designation of birthing-friendly hospitals, and the implementation of that designation and has important potential effects on Medicaid beneficiaries, which are such an important population, and as Julia just presented, experience some of the most, the highest magnitude, I guess, intersectional vulnerabilities. And finally, in clinical care, looking at care bundles and the way that we provide and improve the quality of clinical services is incredibly helpful. And we should also have attention to racial inequities in these and to geographic inequities and other types of inequities, as well as factors that occur, social determinants of health and other topics that my colleague Mary Butler just presented on from the EPC review as well. So I will move on from this slide and dig into a little bit more on postpartum Medicaid extension. The figure that I'm showing here is from a recently published paper where we looked at access to postpartum health insurance for folks that are rural residents. And we look, so this shows rural residents who have Medicaid at the time of childbirth, and Medicaid coverage at childbirth is higher among rural residents than it is among urban residents. What we can see here is that 69% of Black, Indigenous, or people of color who are rural residents had Medicaid at the time of childbirth. In the postpartum period, if we, 41% of those continue to have postpartum Medicaid coverage, and 11% transitioned to commercial health insurance, and 17% became uninsured postpartum. Anyone in those two groups that we're showing here could potentially benefit from continuation of Medicaid coverage of insurance postpartum, because even those transitioning to commercial plans will often have deductibles and other out-of-pocket costs that may delay or may reduce appropriate care. When we look at the picture for white non-Hispanic rural residents who had Medicaid at the time of childbirth, we also see an important population that transitions from Medicaid to being uninsured or to commercial health insurance. But we can see that this policy intervention would have potentially important equity enhancing impacts because of the high proportion of Black, Indigenous, and other people of color in rural communities who are disproportionately affected by postpartum uninsurance or by transitions and disruptions in insurance coverage in the postpartum period. I basically just discussed most of these things, so here's just the words that accompany the data that I was just showing. But the actions to extend pregnancy-related Medicaid could benefit about 1 in 4 rural BIPOC residents and 1 in 6 rural residents. The equity impacts would depend on policy specifics, and I want to emphasize that it is important to pay attention to these intersectional identities in formulating policy to ensure that they actually do have that potential equity enhancing impacts that they could potentially have. Moving forward into a brief research summary of the topics that Julia presented so beautifully. In our research on maternal morbidity and mortality, we have found that Medicaid policy changes, so this is focusing on the Medicaid population specifically, need to account for challenges that are posed by rural locations and by racism. If we continue to implement Medicaid policies that are not attentive to racialized differences in access to care and geographic differences in access to care, they may perpetuate in already existing inequities, but there is a huge potential for reducing inequities via Medicaid policy. For postpartum care content, when we study a single postpartum visit, it obscures information about the content and quality of the care that's being received. We have found that there is a lot of variability across the types in the content of postpartum care, and disparities in care and inequities in care are compounded for patients with multiple intersecting disadvantaged identities. So attention to those intersections is extremely important when we think about postpartum care delivery content and policies. Finally, a research summary on our obstetric care access work, especially looking at rural folks and rural postpartum support. We found that access to care is limited and declining for rural residents, disproportionately so for those who are Black, Indigenous, or people of color and in those communities. Postpartum services and support also decline with hospital obstetric unit closures, and that's disproportionately felt in rural BIPOC communities. The knowledge gaps that we've identified center around postpartum data and intersectional analysis. Those are not standard right now and need to be to inform policy moving forward, and the importance of policy analysis with attention to equity. I'm moving quickly to get to our key recommendations that we have based on the body of work that we've presented here briefly today, but we would love to see work that an investment in data infrastructure for clinical public health and policy analysis for postpartum health. We don't follow people as they become parents and move out into the world as we should in order to better understand and improve their health. It's important from a policy analysis and from a data analytic, whether it's epidemiologic or clinical or social science data, but establishing norms for data analysis and reporting across intersectional identities, not just dichotomized reporting of rural-urban differences or differences by racialized categories, but understanding the intersections of those identities. And analyzing and evaluating policy based on overall effects and equity impacts by these intersectional identities. If you're wondering where to start, we would encourage you to, as you look at results of any analysis, think, how is racism operating here? How might this be different in a rural community? And how might racism be operating differently in rural and urban settings to be producing the kinds of inequities that we continue to see in this country and find unacceptable? Here is a list of some of the references for the studies that we presented briefly, and a link here to the Rural Health Research Gateway, which provides detailed information on a range of rural health topics, and all of our publications that are funded through the Rural Health Research Center are available here. Thank you. I really appreciate the chance to present to all of you today. Thanks to my co-presenter, Julia, and to all of you for being here today.
Wonderful. Thanks to both of you. I love that final photo right there. Wonderful.
Always good to have a smiling baby when we can. Thank you.
Right, exactly. Especially to close it out. Okay, thank you so much. So now we'll move to Dr. Deirdre Stockman, who will talk about coverage, quality, and equity opportunities to improve postpartum health through Medicaid and CHIP programs. Dr. Stockman, thank you.
Thank you, and hello to everyone. Thanks for having me. It's really a pleasure to be in community with so many people thinking about identifying and hopefully acting on opportunities to improve maternal health and postpartum health outcomes. So I'm going to provide a little bit of a different perspective and type of presentation today, but I think it actually dovetails really nicely with the one that we just heard. I come to you not as a clinician or as a researcher in my current capacity, but as someone who uses much of the research that you all do to inform policy development and technical assistance to state Medicaid and CHIP agencies and their healthcare partners in effort to drive improvement in maternal health care and outcomes, to do many of the things that I know a lot of you are discussing these last few days. Before I get into it, I just want to note that I'm presenting, of course, on behalf of a team, a small but mighty one, and want to particularly acknowledge my colleague, Kristen Zeikerman, the lead of the CMS Maternal Infant Health Initiative, for helping prepare this presentation, and more importantly, for doing a lot of the work that I will discuss today. So on the next slide, I have no information to disclose. And the next slide. All right, so why am I here? I'm not a researcher. What? I think there's one slide back. Sorry, we skipped over. Thank you. Okay. So as many of you know, it sounds like you've been discussing Medicaid and the Children's Health Insurance Program, or CHIP, finance or pay for a very large proportion of maternal health care in the United States. And a large proportion of the individuals enrolled in Medicaid and CHIP are in their reproductive years. There are a few different ways of looking at these data. I'm sure you've been looking at a lot of data. I don't have many graphs, and I don't have adorable pictures because I'm from the government. We don't get to have such pretty things in our cleared slides, so you'll have to imagine them. But I do have a few data points to just share to get us started. And they all communicate really the outsized or the important role that Medicaid and CHIP can and do play in reproductive health care, in maternity care, and in postpartum care. All of those obviously slightly different but related things. So nearly 2/3 of adult women in Medicaid are in their reproductive years, and that's among 19 to 44-year-olds. Sorry, we have different ways of slicing the data, so there's some different age ranges here. And almost 25 million of reproductive age were enrolled in Medicaid and CHIP in 2020. Which is a little over a quarter of all Medicaid and CHIP beneficiaries. So as a result, Medicaid finances at least about 42% of births in the United States as a whole. The rate is more than 50% in many states. As you saw in some of the previous slides, a higher percentage in different areas, including many rural areas. And the 42% is based on CDC's vital records data and includes only Medicaid. We've started doing some additional data analysis with our Medicaid and CHIP data in-house at CMS. It's not yet cleared to share publicly, but looking at those, at our data on births over total US births, we think the number is probably a little bit higher, more like 46% nationally. And that has changed during the pandemic. So as more data come out, we'll see how that changed over the last few years. So as healthcare payers, Medicaid and CHIP have a key role to play in improving the quality of maternal health care and postpartum care. And a key driver of that improvement for us is quality measurement and improvement work with states. Before we dig into how we try to use and mobilize some of the research that you all do to inform our improvement efforts, I want to touch on Medicaid and CHIP coverage during the postpartum period. So moving on to the next slide, and I know this was set up very nicely by Dr. Cosimano. A precursor to access to high quality postpartum care, as has been noted by many of you, and other services to improve outcomes, is healthcare coverage. So ensuring access to healthcare coverage is a key opportunity towards improving outcomes. And Medicaid provides pregnancy coverage for about 60 days after birth. Because it's Medicaid and it's always more complicated, technically, it's 60 days after the last day of the month during which the birth or the end of pregnancy, if there was another outcome, ended. So 60-ish, it could be up to almost 90 days postpartum. But as you are aware, and as has been discussed, the American Rescue Plan Act of 2021 established a temporary new option for states to provide 12 months of continuous postpartum coverage in Medicaid and CHIP. And this slide summarizes some of the key implementation guidance. I won't get deep into that. That's mostly for states working to implement the policy. But I do want to note that states also have options through Section 1115 demonstration authority to extend postpartum coverage, and a handful of states are using that option as well. Moving on to the next slide. With respect to the impact of this option, and these are estimates and they're a moving target because the number of states taking up the postpartum coverage extension option continues to go up, which we think is great news. But as of October 1st, we estimated that about 361 individuals annually would be gaining coverage in the 24 states and Washington, D.C., who had opted for the postpartum extension at that time. And about double that number, according to some ASPE, the Assistant Secretary for Planning and Evaluation estimates, a little over 700,000 would benefit annually if every state took this option. And these are additional individuals to those who would have had coverage in the year postpartum based on income. So if you think back to that slide a couple of slides ago that the last presenter shared with that great flow diagram, right? So this is helping to address the coverage gap for individuals who are losing coverage and probably becoming uninsured in the postpartum period. Moving on to the next slide, please. So coverage is a necessary, but of course nowhere near sufficient condition for delivering the kind of high quality, whole person, person-centered care that leads to the improved postpartum health outcomes that we all care about. So we, and I mean all of us here and many of our friends, have to work together on many levels to ensure that the right care gets to the right person at the right time after delivery or after the end of a pregnancy. Many of you here clearly are experts on this, and I am not, but I will quickly, just to level set for the rest of our conversation today, which is to restate what I know you have been discussing, that quality postpartum care is more than a single visit. The American College of Obstetricians and Gynecologists recommendations really describe it more, a more individualized care plan that includes an initial check within 3 weeks, a more comprehensive visit no later than 12 weeks postpartum, and timely follow-up care for pregnancy complications and chronic medical conditions. And in terms of really improving outcomes and reducing mortality in the later postpartum period, usually defined as after 42 days, that kind of follow-up care is really critical and something we're paying a lot of attention to at CMS. The coverage extension really provides an opportunity to address the chronic conditions, other conditions in the longer postpartum period or the longer time after delivery in a much more full and continuous way that people need. And quality postpartum care, as was discussed in the last presentation as well, really should address all aspects of a person's health needs: physical, social, psychological, care for the baby, reproductive health and contraception and birth spacing, sleep fatigue, chronic disease management, as I just mentioned, and other aspects of health. And essentially, ACOG and many others, I think all of us here, state that quality postpartum care recognizes the impacts of discrimination, system inequities, and social determinants of health on postpartum outcomes for Black, American Indian, and Alaska Native individuals and other individuals of color. So moving on to the next slide. So based on the clinical guidelines and recommendations and a scan of the literature and much of the work that researchers here today have done in the past, talking to experts such as yourselves, we put together a bit of a framework to help organize some of the ways that state Medicaid and CHIP agencies can drive improved postpartum care. So where we sit at CMS, our primary role is to work with state Medicaid and CHIP agencies and their partners, health plans, providers, other state agencies, advocacy groups, whoever it may be, to drive improvement in care and to improve delivery of services to Medicaid and CHIP beneficiaries. So we think a lot about the levers of influence that state Medicaid and CHIP programs can change to drive those improvements. So this graphic is not at all complete or comprehensive, and the bullets are just examples, but it gives a sense of the kind of technical assistance that we can provide and how we've structured some of that assistance. Provides a way to think about some of the different ways that state Medicaid partners can focus improvement efforts. So first, improving access to some of the more whole person and person-centered models of care, such as those that include doulas, should also say midwives, group-based care, which refers to groups of individuals who are pregnant or postpartum, as well as team-based care, which refers to the team of providers. Some people get confused because those sound like sort of the same thing. One refers to patients or individuals, one refers to providers, as well as efforts to improve in specific aspects of postpartum care. So we think a lot about and work with state Medicaid and CHIP agencies to look at their data, look at things like what we saw in the last presentation of, where are we doing well? People are showing up for their postpartum visits. Not in every state they are, but, sometimes they are, but then they're not getting some of the individual services to address various different specific conditions. And so an improvement effort could focus on some of those specific needs, such as improving breastfeeding counseling or improving counseling on contraception and birth spacing, addressing depression, maternal depression, and other behavioral health issues, as well as connections to primary care or other chronic disease management, which has been a focus of some of our state projects. And then the top of the Venn diagram here looks at cross-cutting strategies that can be designed to really influence both of the bottom circles. And what I think a lot of folks think about when they think about Medicaid and CHIP has been mentioned before, right? How could we pay differently? How can we structure partnerships and contracts with managed care plans to incentivize the kind of care that we want to see delivered or drive the improvement that we want to see? How can we redesign payment, restructure payment to address some of the things discussed before, such as the gaps in access to care in rural environments, to ensure that folks can access the kind of care they need somewhere proximate to where they live? and other strategies like value-based purchasing, tying payment to improving quality. So in early 2021, we launched the Improving Postpartum Care Learning Collaborative with a webinar series presenting on some of the evidence base and examples of state and health plan initiatives to drive improvement in these areas. And then state Medicaid and CHIP agencies and their partners were invited to join an affinity group to get technical assistance and develop and implement quality improvement projects to drive improvement in postpartum care. 8 states joined that group about a year and a half ago, and we continue to work with 6 of them. 6 continued into the second year, which was optional. So we thought that was great to continue implementing their projects as we close in on the end of the second year. And we're really looking forward to compiling more information about what those states did, what kind of impact they had on their postpartum care outcomes in the future. So stay tuned. We will be sharing findings and learnings from those state projects in the coming year. Moving on to the next slide. I also wanted to mention, as I'm coming, I think, to the end of my time, so I better hurry up. Some of the work that we started last year to better understand the equity of postpartum care quality in Medicaid and CHIP, CMS participated as one of several equity assessment pilot projects coordinated by the HHS Office of the Assistant Secretary for Planning and Evaluation, or ASPE. And this was a project that initially started on a really short time frame. So we started small with just 3 prongs of looking at existing data and research and collecting some additional information from states and from our TMSIS data to better understand the equity and disparities in postpartum care quality that we see in the Medicaid and CHIP populations specifically, in order to inform future efforts with states to drive improvements in equity. And I'm going to move to the next slide since I'm just about out of time, but based on the findings of that equity assessment, we also partnered with the Office of Women's Health to produce the HHS Postpartum Equity and Care Challenge. I think there may be folks on the line who may have participated or may be participating in this challenge to really try to uncover more community-based approaches to improving equity and health outcomes. So we have documented very well the inequities and the disparities in postpartum care and postpartum quality, but we are still lacking and still very much, I think, looking for examples from the community on how to address and improve equity. So our goal with the challenge is to learn about more experiences happening on the ground, what works, what can be scaled up, and how we can help to facilitate sharing across states, across communities, what works to get more and better care to the people who need it. So finally, on the next slide, as I am out of time, you can explore any of these links for further information on what we discussed today. I know the organizers want me to talk about recommendations and needs for further research and learning. So just very quickly, I've alluded to one, which is the need to know more about what works to actually improve equity, what works on the ground in the real world that we can then help to share and spread to others. And from that Medicaid and CHIP program perspective, what we really need are models of care that are broadly implementable and that can be realized at scale. So we love to learn about and from interventions and approaches that were developed and tested in academic research hospital systems and environments. They can be really powerful, but it's often not clear to state leaders or to a state policymaker how to translate that into Medicaid, right? How to describe it in terms of Medicaid coverable services, how to make sure there's enough providers statewide to meet the needs of the Medicaid population, and how to pay for it on a limited state budget. So we're always interested in that really sort of practical and translational research of how do we implement this at a broader scale, and look forward to learning more from folks like you participating in this meeting about what really works as we all strive to improve care and outcomes for the almost 90 million Medicaid and CHIP beneficiaries we have today. So thank you so much, and I look forward to hearing the rest of the speakers.
Thank you so much, Dr. Stockman, and I'm really glad that you could bring in the CMS perspective to this workshop, so thank you for that. And feel free to copy and paste those references that you just showed into the chat if you would like to. Okay, we will now hear from Dr. Eugene DeClercq, and he'll speak on research priorities for improving the quality and evidence base of care. So Dr. DeClercq, go ahead.
Thank you. I appreciate this opportunity. I've been listening to the extraordinary talks we've been hearing so far and making notes on all the things I wish I put into my slides, which are not in my slides. Maybe I'll get to it in the Q&A, or if I ever run into you on the street, then I would be inclined to do the same thing. I have nothing to disclose. I will note that all the work I present is not mine alone. It's with all my colleagues. These are people I've collaborated with over the years. Several of them have been presenting at this meeting. Obviously, anything I say is my responsibility in a formal sense, but I will blame them to myself if there's anything I screw up. This is the theme of the talk. I want to just change the nature of what we try to look at here. And I'm going to use the case of severe maternal morbidity as a case example of that. And so I always use this quote from Goethe, one searches where there's light. And I use that to focus on the severe morbidity, maternal morbidity indicator, which CDC developed, which was a wonderful development at the time. But what has happened is I think it is actually hurt us in the long run, in the sense that everybody just uses this over and over and over again. Having such a convenient measure of a key concept shouldn't be what drives the research agenda and the funding agenda, to be honest. So let me give you some examples. There are literally, if you go on PubMed, about one severe morbidity study a week. I call them the severe morbidity and studies. And the reason is the CDC measure was so easy to apply to population-based databases in states or nationally, people's own hospital databases. And the result is this explosion of studies. And I'm as guilty as anybody else of doing this. The problem is essentially that it's so easy. You apply it and you can track things over time, which we've seen the slides like this already. There's a more recent one that just came out from AHRQ. I would say that out as an acronym, but for me, it comes out as ACK and nobody knows what I'm saying. You see that all the time. You can break it down by subgroups. We love to do that. And this is what we do in public health over and over again. But my question is this: the SMM measure was explicitly developed to be one thing. The definition, the formal definition, severe maternal morbidity includes unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. And it focuses on the time of birth, understandably, because that's a moment we can capture in these databases very, very easily. But does that mean that a condition that occurs in the prenatal period that might either be caused by pregnancy or exacerbated by pregnancy? And does it mean that conditions postpartum don't count? And the answer, of course, is no, but we still focus so heavily on the SMM measure. Here are some of the possible conditions we could use. And we don't measure them because they're harder to measure. We haven't quite figured out a way to get at that. And one of the things I hope that might come out of something like this meeting is a desire to develop a more robust measure that captures not only the events at the time of birth, but the events prenatally and postpartum, because that has been the theme of this meeting. This is not about pregnancy health or postpartum health. It's about women's health, and we need to restructure our thinking around that. So this is just one small example. This is from one of the studies we worked on, where because we had a linked data set, we could look at prenatal hospital contacts and postpartum hospital contacts, as well as delivery contacts. And the column on the right are the number of cases using that already limited measure of birth events to see how often they came up in the 42 days. And this wasn't a year, it was only 42 days postpartum. And the result of this was overall, we were able to find 22% more cases just using those conditions, the 21 conditions that CDC defines. And we're able to expand the base of that considerably. Now, if you go back to this for a second, if you started looking at some of those conditions in the antepartum period, or some of the things that might come up in the postpartum period that don't happen to be one of the 21 magic conditions or procedures, then you expand this much more broadly. So how do we identify cases? A number of ways, right? It could be the diagnosis of a condition. It could be an event. It could be a treatment or an intervention. Where do we find significant systematic data on these things? We look at payment because we can. either in hospital discharge databases, insurer databases, or all payers claims data. The key to thinking about this is all of these are institutionally based measures. And why do we use them? We use them because we can, and understandable, but limited. So I want to apply this to our thinking about postpartum health, and think about what are chronic conditions that might be important to look at, whether the condition is uniquely postpartum or the postpartum manifestation of a chronic condition. I'll use depression as one example. The second is the extent to which we don't use women's voices in all of this. What are the problems they face from their perspective, especially those that don't involve a hospitalization or even an ambulatory care visit? In the case of chronic conditions, this is just one example from another study we had worked on, where we looked at the number of women who had postpartum depressive symptoms. But we had also asked questions, as PRAMS does. This is a listening to mothers study, but we asked questions about their prenatal mental health. And what we found, when you look at this, the two highlighted boxes, that of women who did not have or did not report prenatal conditions of depression, only 3.5% reported postpartum depression. Of those who did report prenatal conditions, 27.7%, about 89% of all the cases of women who reported postpartum depression also reported symptoms of depression in the prenatal period. So whether the condition is postpartum or chronic, we need treatment, but the nature of the treatment may be different, whether it's uniquely postpartum or it's chronic, and maybe the focus needs to be on women's health per se, rather than just postpartum health. The other piece is just the role of mothers' voices. What are the problems they face from their perspective? Since these may not involve hospitalization. So this is from another study. I'm luckily part of the team that works on listening to mothers surveys. This is one just from one of our surveys. And what you can see here are conditions that might involve a hospitalization, right? An infection might lead to a hospitalization, probably doesn't. But in a number of cases, women are reporting constant pain 6 months or more after they've given birth. You're probably saying, does he have more examples of this? And yes, of course I do. Note these conditions. These very likely don't even involve an ambulatory care visit. They might or they might not. And as we've seen, there's so many gaps in our system that we may not be getting to these cases as we need to. And what about chronic pain? You know, we looked at mothers' complaints. In the 2 months after you'd given birth, we were continuing to have pain interfere with your routine activities. And significant proportions of mothers are reporting that. And again, I'm skeptical that all of these cases involved an ambulatory care visit, let alone a visit to a hospital. And so the need to incorporate mothers' experiences into this takes us again out of the realm of just looking at them as birth delivery machines that we have to improve, but that they're women who need to be cared for because they're human beings. So these are some of the areas that get explored in PRAMS. If you're going to think about where do we find out more about women's health, PRAMS is one of the best sources. And these are matters that aren't routinely identified in other data systems. And I'm not going to read, you can read them well enough. But my argument would be we need to extend this. We need to improve it. We need to bring it to, you know, PRAMS is a postpartum survey. One of the dilemmas we've always had is we've wanted to be able to do more surveying of women during their pregnancy to identify cases. But again, it goes to this heart of, is this pregnancy or is this chronic? So knowledge gaps, a few things. Conditions that don't involve hospitalizations tend to be understudied. The need to use more all payers claims databases can tap into ambulatory care. We also need to work more with linked databases that allow you to follow women throughout not only their pregnancy and postpartum, but their life experiences as well. Incorporating women's perceptions in all of this. How do they perceive the postpartum experience, positively or negatively? What role can support play from families, friends, and programs in this postpartum experience? And how do these things vary by race, ethnicity, age, parity, neighborhood? So recommendations: define postpartum health more broadly than hospitalization or even ambulatory care. Consider chronic conditions impacting women's health regardless of pregnancy. Explore what works well in postpartum support, but most of all, listen to women. Incorporate women's voices into assessments of postpartum health as a routine part of the process. I will stop remarkably on time, and I will turn it over to our next speaker.
Thank you, Dr. DeClercq, for getting us back on time. We appreciate it, but also for your important points. Interesting comments in the chat, too, about your presentation, if you have a moment to look there and maybe even respond. So thank you. Okay, next presentation is Dr. Dale Steele, who will be presenting on an evidence review on management of postpartum hypertensive disorders of pregnancy. And I want to note that this evidence review was not commissioned for this workshop, is separate from the workshop, but was being completed simultaneous to our planning for the workshop, and the topic is strongly related. So we invited Dr. Steele to present the findings. Go ahead, thanks so much.
Good afternoon. I have the usual disclaimer. I would note that this research was conducted by the Brown Evidence-Based Practice Center under contract with AHRQ and funded by PCORI. I have had the pleasure of working with a wonderful team of systematic reviewers, clinical experts, with the able oversight of our AHRQ task order officers, representatives from PCORI, and from our partners at ACOG, and many key informants, technical expert panel members, and peer reviewers who will, in the final version, be appropriately recognized. The context here is a systematic review. It was largely clinically focused to at least partially inform and future updates of ACOG clinical practice guidelines. It consists of 3 questions. I would note that it's currently in the public comment period. Everyone on this call is obviously welcome to review and make public comments. It consists of 3 very clinically focused questions. The first is what is the effectiveness, comparative effectiveness, and harms of home blood pressure monitoring or telemonitoring in postpartum individuals? A related question, what are the effectiveness, comparative effectiveness, and harms of pharmacologic treatments for hypertensive disorders of pregnancy in postpartum individuals? And then a somewhat disparate question related to the comparative effectiveness and harms of alternative magnesium sulfate treatment regimens used to treat preeclampsia with severe features during the peripartum period. And a sub-question related to potential adverse medication interactions. Mary Butler did a beautiful job of summarizing AHRQ methodology for systematic reviews. We are currently updating the search, and we'll have, it looks like, about a 10% increase in the number of studies considered. We did include non-English language studies and studies from other countries. We evaluated risk of bias, strength of evidence, extracted data, and then synthesized that both narratively and for key question 3 quantitatively. For all of the studies, we included randomized controlled trials that included more than 10 individuals per group, non-randomized comparative studies that use some sort of statistical technique to reduce bias due to confounding. And for key question 1 only, we added single group studies that approached more than 50 individuals and offered whole blood pressure monitoring. I'm going to quickly go through the studies that we've found thus far relative to each key question. For key question 1, home blood pressure monitoring, it was notable that there were only 3 randomized controlled trials, 1 non-randomized controlled trials, and some single group studies, which we've kind of subclassified into feasibility, implementation, and then quality improvement studies. I'm going to go through each key question and just list our conclusions. Home blood pressure monitoring probably increases submission of blood pressure measurements during recommended time intervals, which should allow early recognition of hypertension in postpartum patients. This was associated with an increased number of blood pressure measurements obtained overall. And importantly, it may compensate for racial disparities that have been noticed in office-based follow-up. Patients appear to be satisfied with home blood pressure monitoring. However, it, at least thus far, may not affect the likelihood of initiation of blood pressure treatment and may reduce unplanned hypertension-related hospital readmissions. We would note for key question 1 that the Heart Safe Motherhood program, which is a texting-based program, has been evaluated both in a randomized clinical trial and in single and multi-center cohorts. Other similar programs have been evaluated. We have found a single comparative effectiveness trial, which is with results in clinicaltrials.gov, but not yet, as far as I know, published in a journal, that supports use of remote communication of blood pressure measurements versus simply having a blood pressure cuff. Limitations appear to be small sample size, and thus far, none of the trials have been powered to detect differences in patient outcomes related to treatment of hypertension. Enrolled participants in the available trials have generally had an antepartum diagnosis, and most of the trials have been performed in urban academic medical centers. In some of the implementation studies, there are relatively low enrollment rates, which may reflect some of the challenges with this work. For key question 2, relating to specific pharmacologic treatments for hypertensive disorders of pregnancy, we found a moderate number of studies, but I would note that that's limited by the fact that they occurred in different settings, hospital versus post-discharge from the delivery hospitalizations, with different timeframes, and used a variety of drugs in different doses, dosing forms, and with various different alternative titration schedules. Having said that, we found 5 RCTs involving a treatment of acute severe hypertension, 5 RCTs that evaluated oral loop diuretics, mostly furosemide, 4 RCTs only that evaluated the effectiveness of other non-diuretic medications for persistent postpartum hypertension, and 2 RCTs that looked at renin-angiotensin system inhibitors on end organ function in postpartum patients. Despite the relatively large number of studies, we really could conclude that there's a single study that had the advantage of using home blood pressure monitoring to evaluate blood pressures after discharge, that does appear to show that addition of furosemide compared to placebo may shorten the duration of persistent postpartum hypertension. But we concluded that there's insufficient evidence regarding the comparative benefits and harms of other antihypertensive medications used to treat postpartum hypertension. We've talked about variable dose and dose escalation strategies. Many studies struggled with dropouts due to limited availability of blood pressures after hospital discharge. And there's quite limited power to detect heterogeneity by subgroup. For example, severe versus non-severe preeclampsia, or to estimate the comparative risk of side effects. For key question 3, we found the largest number of studies divided at a high level between magnesium sulfate regimens that varied by duration, some varied by dose, a few by delivery, and a very few that looked at potential harms. The top line conclusion is that there's insufficient evidence regarding the risk of eclamptic seizure with shorter duration regimens. But as will be probably obvious to the clinicians, reduced duration of magnesium sulfate treatment was associated with shorter duration of urinary catheterization, shorter times to being able to ambulate, probably reduce the time to start breastfeeding, and may reduce the time from delivery to contact with the infant. This slide is busy, but I would note that virtually all of the studies, except for the top two, were performed in low and middle income countries, and many of the studies had no seizure events in either group. And it's that's typical of this literature, and one of the reasons why conclusions about relative risk of seizures is difficult. For key question 3, we found studies that looked at lower dose. Not surprisingly, those studies that used lower doses had lower rates of early signs of magnesium toxicity as manifested by absent deep tendon reflexes. There was a suggestion in some very high-risk populations that lower doses might increase the risk of recurrent seizures in patients who had presented with eclampsia. There are a few studies of alternate delivery studies. I think overall, the benefit is there are a small number of traditional regimens. The Zospan IV regimen, most commonly used in the US. Duration of treatment is somewhat inconsistently reported. And importantly, none of the studies describe patient-reported outcomes, such as the overall postpartum experience, breastfeeding success, or opportunities to bond. And they were virtually all performed in non-US settings, which may severely limit applicability. For key question 1, there's clearly a need for large pragmatic trials powered to detect clinical outcomes. It's quite clear from looking at the entirety of the studies that home blood pressure monitoring involves multiple intervention components, all of which may be critical, including education, technical aspects, and whether these patients are actually treated based on the results, the blood pressure readings that are reported. So it's quite clear that there's further research needed to identify optimal implementation components and strategies tailored to community and individual needs and risk profiles. For key question 2, medications are used that have not been studies in randomized controlled trials, including medications like amlodipine, a calcium channel blocker, and hydrochlorothiazide that may have a better side effect profile or be easier to take due to other decreased side effects or decreased dosing interval. There's a need to identify clinical factors that may predict a favorable response and compare side effect profiles, particularly headaches and effects on mood. Further study is needed to confirm the possible end organ protective effects of angiotensin II receptor blockers and converting enzyme inhibitors. And as a subtext, existing beliefs that race may modify treatment effects for specific medications should be critically evaluated. Regarding magnesium sulfate treatment, shorter durations of treatment may well be decreased maternal side effects and the maternal experience. And alternatives to dosing regimens may be improved with clear that overweight and underweight individuals may need different dosing strategies. So in conclusion, home blood pressure monitoring probably improves ascertainment of blood pressure, allowing early recognition of hypertension in postpartum patients, and may compensate for racial disparities in office-based follow-up rates. Furosemide may be useful in postpartum period. Further evidence is needed regarding other medications, and regarding magnesium, this sort of goes without saying, the lowest effective dose to minimize unpleasant side effects and toxicity for the shortest effective duration may be preferable. Thanks.
Wonderful. Thank you so much, Dr. Steele, for your presentation. I will now turn it over to Corinna Davidson, our panel chair, for our discussion session. And at this point, we will bring back all speakers from this session, starting with Mary Butler on down. Thank you.
Thank you so much, Kate. So if the speakers from this particular session can go on screen, we'll start seeing if there are some questions for you. So I'm going to start with Dr. Butler's presentation and ask first if any panel members have questions or comments or clarifications that they'd like from Dr. Butler.
Karina, feel good?
Yes, please, John.
Hi, Dr. Butler. Thanks for the presentation. I have a nitpicky question and a broader question, if I could. There was one study, and I apologize because the order of the presentations, I couldn't figure out which presentation this was going to be on. There was a study that compared care for women of Mexican origin in California, I believe, that found an increased morbidity rate in one group and but not an increased mortality rate. And the conclusion of that was that there was a difficulty with quality of care intrapartum, I think. And I just wanted to understand how you came to that conclusion and whether there potential, whether you came to the conclusion or the authors did, or whether there are other potential explanations considered for that. I'm not sure if you remember the study I'm talking about.
Yeah, it is ringing a bell, particularly because of the border questions related to it, but I'm afraid I do not particularly remember. We did not, as a general rule, try to reinterpret the results that were presented. We were reporting their results. So if that helps answer that question.
And their potential explanation for those results, maybe, or something. Okay, all right. That's fine. Thank you. I realize that's a hard question to ask you. The second one was, you've said a couple of times in these presentations that you wanted to sort of embrace the complexity of the results by presenting the rather spaghetti-like alluvial diagrams, but also make a call for better explanation of mechanisms and pathways, which would seem to be on the more reductionist side of that. And understanding that we probably have to understand all of this much more. Do you have specific analytic methods or statistics in mind when you talk about understanding complexity of this, hierarchical models or more complex models? Or is it just a need to recognize that this is complex, but then we also have to do the more reductionist figuring out of pathways and mechanisms? How would you reconcile those two?
Right, and I think that has to do with thinking about what are the potential places to intervene, and also to potentially to help people understand, to interpret and tell the stories better. So I'm thinking about the statement of needing to understand the mechanisms through which things are happening. Right. Understanding and trying to pull apart what are the black boxes, and let me put it another way. One of my general statements is we absolutely need to teach resilience to people. We also absolutely do not have the right to expect their resilience to be the answer to problems, right? And so, it is unfortunately or fortunately one of those both and kinds of spaces where sometimes digging into the lower levels of a system, at which point a whole new system tends to reveal itself, the complexity of that space, at that level of a system. So thus understanding the mechanisms sounds mechanistic, but it's still embedded within that life system, right? So it's thinking about what level of these living systems are we using our telescope or our microscope to try to clarify our understandings. So it really feels to us like a both and kind of space to work with. And yes, absolutely, the study designs that we'll need to use certainly is at the larger level is going to need to work in that space of the pragmatic trials and the complicated, rigorous designs that we do try to use for a causal mechanism at the epidemiological study level too. Sorry, that was.
I didn't expect a single answer. I know it's complicated, but I appreciate it.
I also have a question for you, Dr. Butler. In trying to understand the different evidence bases that you were using for the different exposures, I was trying to sort of cross-map between your eligible studies and the alluvial graphs. I assume that some studies are represented in multiple alluvial graphs. Is that correct?
That is correct, particularly studies that had both what we were terming as primary and social determinants of health showing up as both primary and secondary roles. So for example, socioeconomic status related variables showed up secondarily to many other types.
Got it. Okay, thank you. I've got a couple of questions for you from the audience, unless other panel members have questions for Dr. Butler. Okay, the first question is there any way of understanding why there are fewer studies on the role of racism, either structural or societal, and disproportionately more on interpersonal violence, which potentially locates the problem at the individual level and may blame the victim and reinforce stereotypes?
Mm-hmm. If I could point to one thing that I think Dr. DeClercq talked about earlier, which is precisely that we look underneath, we look for answers under the lamppost that's available to us. And because PRAMS does have some of those violence-related variables, PRAMS was, the violence-related studies did not solely rely on PRAMS. There were other data sources that were used. But I do believe that that's, that's part of it. Another that I would like to recognize and acknowledge is that I think I'm speculating here based on the screening process that we went through to develop the literature, that if we were to pull together and look at the qualitative research that tries to examine the impact of social determinants of health as factors, that we might learn more there with regard to racism and the experience of racism. We're just frankly quite sad that the literature set was already large enough that we just did not have the capacity to incorporate that type of literature.
Okay, you've partially answered the second question, but I'll pose it just in case you have further elaborations you want to add. The second question is, how might research on the role of racism be advanced, given in part that its surveillance and data reporting may be much less developed than surveillance and reporting on, for example, domestic violence or interpersonal partner violence?
Right. And I think that there's, a rich load of information in that qualitative research that if that were pulled together, could be extremely informative in terms of thinking about what kinds of new data sets might be really valuable, from a surveillance mode, right? Because that's going to be a very challenging area to work in. There's so many brilliant people who've been part of this workshop that I'm sure that if that information were available, it would be put to good use.
Great. Thank you so much.
May I ask a very quick question, Dr. Davidson?
Please.
Sure. Dr. Butler, thank you so much. And thank you for the presentations over the last few days with the entire team. I know we talked more about the environment yesterday, but given the conclusion that most of or all of the studies, you could not rule out bias, can you just comment on the theme of the environmental exposures that were measured? Because my understanding is some of the studies that have been published used EPA data and other kinds of data that were not self-reported. But I guess what was your impression about that literature that then had some issues with causality? If you could comment on that, or?
Well, I don't think that there's anything unusual or particular to the environmental factors literature. I'm just taking a really quick look back into the into my whole report here, because I was looking for the we had studies that covered green factors, pollution, and heat exposure in particular for the environment, the types of studies for environmental. And again, it's oftentimes the largest challenge lies in the area of concerns about selection bias, and then concerns about other plausible counter stories and unmeasured variables, that could be at least even partly explanatory, right? So beyond that, I just don't know that there's anything in particular that I would say was unusual to the environmental studies that wasn't present in any of the rest of the study designs.
Okay, thank you so much.
Okay, if we now move to the session policy to improve postpartum health equity, do any panel members have questions for those two presenters? Okay, I'm going to move then to opportunities to improve postpartum health through Medicaid and the Children's Health Insurance Program, coverage, quality, and equity. Do we have any questions from the panel members about that session? If not, Dr. Stockman, I have one question from the audience. This is it. As it relates to support of patient and provider requests for extended postpartum care, is there cost-benefit analyses or data documenting benefit to society, the government, or commercial payer?
That's a great question and a tough one. I am not aware of anything that CMS has done on that front. I don't know if any of the other panelists are aware of studies that other folks outside of the government may have conducted to try to identify the cost-benefit analysis. I'd love to hear about it too, but I'm sorry, can't think of any.
Yeah, I'll pause for a moment in case any of the panel members or previous speakers. So that's a great gap to cover. I have a follow-up question, Dr. Stockman. You suggested that there may be a reduction in inequities as a result of this. Similarly, are there quantitative analyses documenting that, or is that a hypothesis at this point?
Great question. I think that crosses over a little bit of the presentation that came right before me as well, looking at who stands to benefit from the coverage extension, and that there's a greater proportion of Black, American Indian, Native, Alaska Native, individuals who lose coverage after 60 days postpartum, and particularly in some rural areas. So from a coverage perspective, I do think that there's very suggestive data that part of the gap that will be closed in terms of coverage will address some equities that, it's another step. Will require more research to then follow up on whether that leads to better outcomes down the road. I think it's easier at this point to say yes. Reductions in inequities in coverage are expected, and I think already starting to be documented. We're obviously just about 8 months into the coverage extension now, so those data are still coming in terms of who is gaining coverage, and it will be certainly an important thing for the research community to track over time to see how that impacts equity in outcomes as a result. The other thing, back to the first question, somewhere it might be findable to see how Congress and the Congressional Budget Office scored the American Rescue Plan Act, which may actually have some of that cost-benefit data in it. So whoever asked that question before might want to look at the scoring for the law and see if there might be some, probably not going to answer all the questions, but might be some methodology and data to take a look at there.
That's wonderful. And I'll just ask one follow-up question to the second part. Coverage extension, when you're doing the analyses of the first 8 months, you're looking at utilization as well as coverage extension?
Oh yeah, I'm sorry. That was confusing. The provision, the option for states just went into effect 8 months ago. So in that sense, I meant we're just 8 months into the policy existing
exactly.
Or being implemented. So that's why, we're still kind of collecting data on who's affected by the extension.
Got it. Okay, I'm now going to move to the next session, asking different questions, research priorities to improve the quality and evidence base of care for every woman and every child. Panel members, any questions or comments for Dr. Clerk? I see Dr. Timmermans.
Yes, I do have a question. First of all, I want to thank Dr. de Klerk for this really intriguing and interesting presentation. And I especially appreciate the point of thinking of postpartum care as a women's health issue and starting by listening to women. But I just want to make sure that I understood the beginning of your presentation. And so my understanding was that you argued that the measure of severe maternal morbidity has skewed the knowledge base of what we understand under postpartum care. And if that's the case, I was wondering whether you could elaborate a little bit more on the consequences of this, this development.
Sure. I mean, by looking, oops. Sure. Yeah, I wasn't sure I was unmuted. By looking only at the birth event, which is how the measure is developed, we ignore the events that happen during pregnancy and postpartum. And I have no objection to the original measure, but I'll note that when we published our piece that used linked data to look at prenatal events and postpartum events, the person who developed the original, or led the development of the original measure, Bill Callahan at CDC, said it's about time we move beyond the birth event to start understanding what severe morbidity is about. However, all we did was take those same 21 conditions and diagnoses and procedures and apply them to those other periods. My point is we need people with more clinical experience than I to start getting into the question of what should we be looking at in the prenatal period? What should we be looking at the postpartum period?
Thank you.
Okay, thank you. And the last session was evidence-based practice center presentation. Just want to check in quickly to see if any panel members had any questions or comments for Dr. Steele.
If not, can I just make a comment about an earlier point?
Please.
Okay. On the policy front, I mean, what we need to understand is two things. One, asking different questions can lead to different policy. The whole question of the postpartum extension was driven in part because CDC started reporting the timing of maternal deaths. And when they had that breakthrough about 6 years ago, where they reported it as, you know, at one point it was about a quarter, in their most recent publication, almost half the deaths that they were counting as pregnancy-related deaths occurred in the postpartum period. That's the kind of thing that can happen when you present what had been familiar data in a different way, because people started to ask the question of, well, wait a minute, if women are dying in this period, why are we not covering them for a longer period of time? The other irony of all this is, remember, the postpartum extension involves the more generous allotments of coverage that wouldn't be necessary if we simply allowed women to get coverage anyway, right? We're talking about the difference between a Texas at 18% and a Texas at 205% of the poverty level to qualify. You know, if you're not pregnant, it's 18%. If you are pregnant, it's 205. If that's the case, if we just covered it up to 205 all along, there'd be no issue about postpartum extensions. It's just a manifestation of our focus on women's health as only being related to pregnancy and birth.
Right. And on that note, I'd like to thank the morning's excellent speakers for their very thought-provoking talks, and let everyone know it's now a lunch break. A reminder, please stay logged in, but simply mute so that you can come back at 1:45 Eastern Time.
Welcome back, everyone. Thank you for joining us, continuing to join us. Okay, we will continue our afternoon session. We have one more key question 2 session to run through today, and then we have a couple of talks and then a roundtable session and then a closing keynote. So we will begin our last key question 2 session with Drs. Davis, Miller, Osborne, and Hoffman. And we will begin, I want to make sure I get this right, with Dr. Isa Davis. Dr. Davis, go right ahead. Thank you.
Can you hear me?
Yes.
Yeah.
Okay, wonderful. Thank you. Sorry. Good afternoon. So my name is Isa Davis. I'm a family physician and health services researcher in maternal health and health disparities at the University of Pittsburgh. And I am grateful for being a part of this conversation and share the work that we're doing in this space. Next slide. So I have no financial disclosures. I only have one. I am on the United States Preventive Services Task Force, but this is not an official talk, and so this talk should not be attributed to the task force. Next slide. So we have learned over the past 2 days of the severe maternal morbidity and mortality and the related racial disparities that are persistent and increasing in the United States. Next slide. And that obesity, as noted in the red line, continues to be a major health problem and is associated with adverse pregnancy outcomes and continues to increase over time, and that greater disparities of obesity-related adverse pregnancy outcomes are seen among Black women compared to the other women. Next slide. We've also heard about hypertension disorders of pregnancy, how they are increasing in prevalence, and is a major contributor to maternal deaths. Next slide. And looking a little closer, this is, for example, in a study done by my colleague, we see that blood pressure is higher for Black women postpartum who have a hypertension during pregnancy, especially within those first 6 weeks after pregnancy. And in this slide, Black women are the top line and white women are the bottom line. And as you can see, while blood pressure declines, systolic, diastolic, and mean arterial pressure decline for both groups of women. Overall, Black women have a higher systolic, diastolic, and mean arterial pressure compared to white women, even when they receive the same standard of care. Next slide. So we've also learned about the many challenges to addressing maternal health disparities with the themes of structural and systemic racism and inequity and social drivers of health, how Black and Brown persons are often not seen, heard, or valued in the medical system, the inefficient or insufficient attention and support in the postpartum period, the insufficient partnerships with community health professionals, and the insufficient diversity, equity, and inclusion within our biomedical and research workforce. Next slide. So kind of summarizing some of those major themes from the evidence, we've learned that Black mothers and birthing persons have the highest pregnancy-related deaths, and that conditions such as hypertension, obesity, and we'll hear later today, peripartum cardiomyopathy are major drivers of pregnancy-related mortality and long-term CB health. That postpartum period is a window of opportunity to address these social drivers of health as well as prevent chronic disease, and that there's a lot of evidence involving community health workers improves our health outcomes and self-advocacy in pregnant people. Next slide. So on medical teams, this collaborative care model involves multidisciplinary teams of members, so doctors, nurses, social workers, psychologists, and we know that these collaborative medical teams improve health outcomes. So I want to talk today about expanding this collaborative care model to integrate community-based teams to the postpartum care to promote heart health and equity. Next slide. So we know that addressing the life essential eights, so diet, exercise, cholesterol, smoking, blood pressure, blood sugar, and sleep can improve cardiovascular health. And that medical teams spend time addressing these when patients come for care those few times of year. But then patients go back home and they spend most of their time in the community. And so this is an opportunity to partner and train our community-based teams to better help us address the life essential eights and improve cardiovascular outcomes. Next slide. So collaborative care that integrates these community-based teams is an important approach and opportunity as it can help us to lower those social barriers, increase access to health information and services, reach populations that are hard to reach, focus on prevention and management of disease, and connect populations to medical services earlier. And that the benefits of collaboration with community-based teams are that these are trusted sources and often represent the communities they serve. They are able to provide evidence-based education as well as social, cultural, and emotional support, and they help patients access or navigate medical and social services. And we've seen some examples of these over the past few days, the lactation specialists, community health workers, doulas, and home visitation programs. Next slide. So I want to highlight just two examples of community health worker programs that have been used to improve maternal health postpartum. So one is the We Care program, which was done in Central Indiana. This was a prospective study of 1,500 women from the highest risk zip codes. And they use community health workers as and provided health coaching to support maternal and infant health across a variety of psychosocial and cultural needs, with the aim of decreasing infant mortality risk factors. And they showed that with their intervention, they were able to lower low birth weight and improve maternal risk behaviors. And then the second program was done in Tennessee, a maternal infant health outreach workers program. And this was a home visitation program implemented in early pregnancy to 6 months postpartum. And they used community health workers that were peer mentors to support the perinatal health of Hispanic mothers. And they showed in this intervention an improvement in breastfeeding duration, safe sleep practices, stress, depression symptoms, emotional support, and referrals for follow-up to medical care. Next slide. And so as we heard yesterday, doulas provide support to pregnant persons during pregnancy until delivery, and postpartum doulas are specialized in providing postpartum care and recovery. They are performing services such as light housekeeping. They support breastfeeding, assistance with newborn care, and help with referrals to local services and local resources and medical services. Next slide. And so I want to talk about our team's established partnership with Healthy Start organization that we've been using to help address heart health and equity. So Healthy Start is a community-based program consisting of a multidisciplinary team of community health workers, lactation specialists, nurses, doulas, mental health specialists, and childbirth educators, mostly from the communities that they serve. And they provide support to pregnant and postpartum people and their families to improve maternal and child health, reduce poor birth outcomes and mortality, and promote equity. And they serve about 80% of women and infants of color in our southwestern Pennsylvania area. Next slide. And so we are partnering with Healthy Start on a recently funded randomized control trial that aims to test an enhanced care intervention that consists of both a medical component and a community-based component, which I'll talk about more in a minute, versus our usual kind of medical care intervention to reduce severe maternal morbidity and improve heart health in patients that have a hypertensive disorders of pregnancy. And as you can see from our team, it's important to have a multidisciplinary and diverse team that brings together our community partners, our medical and our research team as equal co-investigators. Next slide. And so our RCT's approach is to eliminate racial disparities in mean blood pressure in the year after delivery among women with a hypertensive disorders of pregnancy by leveraging our well-established kind of home blood pressure monitoring program with our community partnership with Healthy Start. And our goal is to improve blood pressure postpartum to decrease the incidence of chronic hypertension and improve CV health. Next slide. And so this is our overall study design. I just want to point out that we will be randomizing 450 women to usual care, and in our medical system, that is a well-established home blood pressure monitoring program that is delivered over 6 weeks postpartum, compared to our enhanced care arm, which is that medical home blood pressure monitoring program, plus the addition of a heart health postpartum doula that will provide support, education, and referral with a goal of, again, lowering mean arterial blood pressure in a year. Next slide. And so just a little bit about our doula intervention. So our postpartum doulas are highly trained, trusted caregivers that support postpartum care and wellness. And their skills are going to be augmented with advanced training and modules that address the life essential aids so that they are able to support the education of participants on blood pressure and CV health, and also be trained with appropriate referral resources. And that all aspects of the doula intervention will support into the new skill acquisition for mothers to provide support for self-management of physical and emotional health, and to cultivate opportunities for socialization and encourage accountability. Next slide. So in the first 8 to 12 weeks of our intervention, they'll have one-on-one doula support that will provide health education, again, specifically addressing the life essential 8 cardiovascular risk factors. They'll help support the adherence to the blood pressure monitoring and medications, and assist in connecting these women to healthcare as needed. And then in the latter part, the weeks 9 to 12, they'll transition from individual doula support to a doula-led peer support, and that these groups will be used to reinforce their skills and support ongoing blood pressure and weight management. And I look forward to coming back to you to telling you the findings of our trial at the next workshop. Next slide. But I do want to spend just a few minutes on the home visitation program that address maternal health. And the evidence of these programs to date is that postpartum home visitation programs conducted by health professionals such as nurses or laypersons may prevent health problems from becoming chronic. They've been shown to increase maternal satisfaction with postnatal care, improve exclusive breastfeeding rates. But the research gap really is in that there's insufficient evidence that these home visitation programs decrease newborn or maternal deaths or serious maternal health problems. Next slide. And so I want to highlight just some examples of some home visitation programs that have been researched. So the first is a Texas program. In Texas, they have a group of, they screen women postpartum at the well child visit for postpartum depression. And then they, if they're positive, refer them to psychiatrists. But there's not enough psychiatrists to meet the need. And a lot of the Black, Latina, and women on Medicaid were less likely to attend those psychiatric visits. And so what they did was they provided a home visitation program with social workers to these women. They randomized women to the home visitation program with social workers versus a psychiatric referral, and found that this home visitation with social workers was just as good as the psychiatric referral and showed a decrease in postpartum depression symptoms and increased maternal self-efficacy. And then there's the family checkup home visitation model, which is a well-established home visitation program that promotes positive child behavior by focusing on improving parental skills at key developmental transition periods in families that experience adversity. And there's been interest in leveraging these home visitation programs to be able to address more health outcomes for the mothers and the infants. And that leads to the next slide, the ENRICH study. And this study, it does just that, expands this family checkup home visitation model in early childhood to promote cardiovascular health of mothers and young children. Next slide. And so this is a multi-center trial of 7 sites, of which Pittsburgh is one site, sponsored by NHLBI. And the overall goal, again, is to improve the cardiovascular health of mothers and children by adding this cardiovascular health education and promotion and intervention to the family checkup home visitation program as a means of improving cardiovascular health of moms and their infants, and doing this again with a multidisciplinary team that combines both medical research and community-based teams. Next slide. And so this is, again, our Pittsburgh team for this study, and I just wanted to highlight it again because it's a multidisciplinary team, diverse, and brings together our community partners within our co-investigative team, providing valuable input, delivering the interventions, and being an important voice for community that it participates. Next slide. And to summarize, so the knowledge gaps are really, I showed you, mentioned 2 trials that are currently in the field, but there is room for more RCTs to evaluate home visitation programs to understand the frequency, timing, duration, and intensity of home visits on maternal and infant health outcomes. More research to establish the evidence base on effective strategies for integrating and evaluating the medical and community partnerships that deliver this postpartum care, and to evaluate the effective communication transitions of the collaborative care between medical and community-based teams, and the role of technology and how it may help in facilitating that communication. Next slide. And finally, so the recommendations are to continue funding collaborative care models that integrate both medical and community-based teams to deliver postpartum care, issuing RFAs that will require the prominent roles of multidisciplinary teams, community partnerships, and that explicitly address equity and social drivers of health, and then create a repository of evidence-based training modules for community health professionals on addressing the life essential 8 cardiovascular factors and the structural and social determinants of health in the perinatal period. And with that, I thank you for listening.
Thank you so much, Dr. Davidson. Sorry to rush you at the end. There is one question for you about home visiting services in the chat, which is interesting. Okay. So thank you very much. So we will now move on to Dr. Emily Miller, and she'll be identifying and addressing postpartum mental health concerns. Thank you, Dr. Miller.
Thank you so much. Just a quick audio check. It's working okay still?
Sounds good. Thank you.
Oh, success story. Okay, excellent. I'm so excited to be here. This is an area I'm incredibly passionate about. I'm Emily Miller. I'm a maternal fetal medicine physician scientist, health services researcher. I'm at Brown University in Rhode Island. Next slide. This is my disclosure. I will not be talking about COVID vaccines. Next slide. I want to begin this conversation with my why I do the work that I do. And it stems from the great privilege I had to care for the woman whose hand is depicted in this slide. She was someone I got to care for early in my career. She came into my care with perinatally acquired HIV, meaning she had acquired HIV at the time of her delivery. And she was delivered in the early 90s, which was a time where there really weren't a lot of antiretroviral medications available. Those that were big, bulky, required complex regimens or timing throughout the day. They had a lot of toxicity. It was a medication regimen that was hard for adults to take, much less a child or an adolescent. It was also a time with enormous amounts of stigma around HIV. And so you could imagine she developed significant depression, stress, anxiety throughout her childhood. But she really wanted to become a mother, and so we wanted to support her in doing so, despite her drug resistances, despite her viral load being 400,000. And when she came into our care, I had studied HIV perinatology backwards and forwards in my MFM training. I had an amazing mentor, shout out to Dr. Garcia. I had read all of the guidelines. I knew drug-drug interactions, pharmacokinetics of these medications, all the science I could possibly know about HIV in pregnancy, I knew. And so I knew that me and my team, we were equipped to care for her, or that's what I thought. Her viral load in the beginning of pregnancy went from 400,000 down to 400, and I thought we were rocking this. And but at 24 weeks of pregnancy, she didn't show up to her prenatal visit, and she didn't answer our phone calls, and she didn't answer the door for the enhanced case managers that were involved. And what we later learned is that she had had an altercation with a family member that precipitated a recurrent major depressive episode. And her depression had her completely step away from care, stop taking her medicine. I got to see her again when she was admitted to the hospital with shortness of breath at 32 weeks of pregnancy. She was diagnosed with something called PJP pneumonia, a really bad pneumonia related to AIDS complication. And she quickly deteriorated, got transferred to the ICU, was intubated, and went into preterm labor. She delivered this beautiful, healthy, HIV-negative boy, and never gained consciousness, never realized she had made her dream of becoming a mother. She passed away, this 21-year-old woman, 3 weeks postpartum. And I share this story with you, next slide, to emphasize the concept that mental health is maternal health. And we can learn and know everything we need to know about the biology of pregnancy or any specific disease state. But if we don't pay attention to mental health in pregnancy, we're going to lose people like my patient. I also reflect a lot about her, certainly, but think about her death certificate. And her death certificate says that she died from pregnancy complications and respiratory distress or respiratory failure related to PJP pneumonia, related to AIDS, related to HIV, but nowhere in that death certificate does it really say why she died. And she died from an untreated major depressive episode, at least in my mind. And so I think when we look at the statistics about perinatal mental health being the leading contributor to maternal mortality in the United States right now, I think we're just seeing the tip of the iceberg, because I think it's a leading contributor to so many other manifestations that ultimately lead to people dying. Next slide. I shared this slide 2 days ago, so I won't belabor it, but the point that I want to make with it is that the treatment of perinatal mental health conditions isn't an instant thing. It's a cascade. It requires identification of the mental health need, initiation of treatment, adequate treatment, and then remission. And we're failing. We're unequivocally failing. Contemporary meta-analytic data demonstrate to us that 3 to 5% of people with perinatal depression are achieving remission of their perinatal depressive symptoms, 3 to 5%. So we have to do better. Next slide. Now, I have the privilege of following Dr. Davis, who talked about collaborative care, which is fantastic, but I'm going to talk a lot about the perinatal collaborative care model, because this is, again, an innovation on what exists in the collaborative care literature. So collaborative care is kind of an intensive and very structured health services intervention that is quite complex, but I'll distill it down in my very obstetrician pragmatic mind to the 3 core elements that are distinct from standard perinatal care. The first is a care manager, typically a licensed clinical social worker, someone with some mental health expertise, who serves as the hub of the system, who can coordinate some of the care between the obstetric clinician and the pregnant person. The second really important component is a patient registry. So the concept here is everyone that comes into the program goes into a registry where their symptoms are tracked. So when we see that people aren't responding to their first treatment, we can find that really early. We're monitoring their depression symptoms, their anxiety symptoms, and making sure that whatever we're doing is getting to symptom response and remission. And then finally, my favorite part, and what Dr. Davis talked a good bit about, is the weekly interdisciplinary team meetings. And I think this is the magic sauce. The chance for me as an obstetrician, my care manager, and my psychiatry consultant to sit in a room together and talk about everybody whose care is not improving according to what we think it should, what should be happening. And we then recommend adjustments in the care plan to make sure that we're getting to a goal of population level remission and depressive symptoms. Now, this is just the backbone, and I think there's so many opportunities for innovation that would require rigorous evaluation, and we'll get to those recommendations at the end. Bringing in community health equity advocates or community workers or doulas or lactation consultants, I think we can only build upon this foundation, and that part really excites me, but I think understanding the core is really essential. Next slide. Now, I talk about collaborative care, but this isn't my idea. I'm standing on the shoulder of hundreds, if not thousands, of giants who have come before me, who have done the formative research in primary care to demonstrate that the collaborative care model is effective, efficacious, cost-effective. It works really well in the primary care setting. And we can certainly talk about this more in the discussion, but I don't think that primary care and obstetric care are necessarily equatable, because I think there's really some profound differences on the patient, the provider, and the health systems levels. Next slide. So I think it's important to look at, so what do we know in the specific context of perinatal care? Well, it comes from two trials done by Dr. Grote and Dr. Melville that demonstrated that that implementation of perinatal collaborative care led to improvements in depressive symptoms compared to usual care. Next slide. But when I think about these slides and I think about the gaps in our healthcare system, what these trials did, and I have nothing bad to say about them, they're phenomenal, phenomenal efficacy trials, but they started an intervention after somebody had been screened, after somebody had recognized that screen was positive and had recommended treatment, and after that person had agreed to begin treatment. And so it's really looking at the distal aspects of the care cascade, and they're super important to look at, but we need to look at not just the efficacy at that point, but effectiveness on a population level when we implement this change. Next slide. And so what we did, I was at Northwestern University in Chicago up until 5 months ago. Really grateful for my time and colleagues there, and we were able to put together this system called Compass, which was implemented in January of 2017. It served 5 diversely structured obstetric care offices delivering the collaborative care model. Around 5,000 pregnant or postpartum people were eligible for referral annually, and anyone who came in was followed for 12 months postpartum. Next slide. So these are some of our data that have been published, and what we wanted to look at are those more proximal aspects of the care cascade. Did implementation of collaborative care change obstetric clinician behaviors, increase our ability to screen, and increase our recommendation for a treatment when someone's screened positive? And what you can see from this bar graph, pre-Compass is in blue, post-Compass is in purple, that there are significant increases in screening. And I sincerely believe that's because obstetric clinicians want to screen, but it's futile to screen if you know you're not going to have the resources to give care to that person. And we've already talked over the course of the past few days about how many barriers to care there are. But when those resources are embedded, then absolutely, right, screening increases. So not 100%, but moving in that direction, and this is just over the first 2 years. Same thing for those who screen positive, a treatment recommendation. I will note I don't expect this to be 100% because this is just of those who had a PHQ-9 score that was greater than or equal to 10. So not all of those will have major depressive disorder on diagnostic evaluation, but again, an important increase in the recommendation for treatment with people who are exhibiting symptoms. Next slide. But I think it's important to note that effectiveness and efficacy do not always translate to equity, and it's not uncommon when we look at health services interventions that we see population level improvements in health, but widening racial and ethnic disparities. And so it was intentional that when we started Compass, we wanted to look at subgroup analyses, and we specifically wanted to focus on Black women versus women who self-identify as white, because we found, because of all of the literature that we've described over the past couple days. Next slide. So just to take a moment, because this is a little bit of a complex graph, the dyad of bars on the left are before implementation of COMPASS. The dyad of bars on the right are after implementation of COMPASS. The blue bar are people who self-identify as whites. The green bar are those who self-identify as Black. And what I want you to see here is that before implementation of COMPASS, we were more likely to screen people who identified as Black compared to those who identified as white for perinatal depression. After implementation of COMPASS, that disparity went away. And on the surface, you may think, well, that's not bad that we're trying to screen people more. Maybe when I think back to Dr. Simon's giving tree example, maybe that's a health equity promoting intervention. But I would argue that variation in care due to non-clinical factors and biases is an impediment to quality care. And that in the context of perinatal mental health care, clinical care should never favor depression screening in one racial group over another. There's just no rationale for that. And these findings persisted after propensity score adjustment and multivariable models. Next slide. This next slide pertains to treatment. And what's profound to me here is that, remember, not only were we screening Black women more often, but we were recommending treatment less often. Right? So screening more, but then not recommending treatment. So it's hard for me to imagine that there was anything more than implicit bias that was promulgating our decision to screen. And this disparity really is alarming. But that disparity was mitigated after implementation of COMPASS. It was not significant any longer, and that persisted with propensity score adjustment. So in my mind, these findings all point to the benefit that healthcare systems can have by implementing a standardized care for perinatal mental health, like the collaborative care model, that supports systematic and equitable processes across the population. Next slide. So it's easy for me to say the collaborative care model, but I think it's important to recognize that health services interventions are complex, and implementing them is not, it's not like taking a pill every day, right? It's something that requires an understanding of implementation strategies as well as implementation outcomes to really understand effectiveness. So our group has started to think about implementation strategies, and we've used the EPIS process framework to start to get at within COMPASS what we thought was effective with some qualitative work that was done, but I think there's so much more to be done. Next slide. So knowledge gaps that are here, and I grouped them into two buckets. The first is effectiveness of the collaborative care model. I think questions that remain in my mind are, does implementation of the collaborative care model in the perinatal setting lead to improvements in depression symptoms, response and remission, or other outcomes that are related to perinatal depression, like suicidal ideation or opioid use, contributors to maternal mortality? Does the collaborative care model lead to improvements in some somatic health outcomes like gestational diabetes, preterm birth, preeclampsia? There's no reason in my mind that we wouldn't start to see differences, because as it turns out, when you treat people holistically, you actually can improve health. And then finally, are these effects that are seen equity promoting? Next slide. Knowledge gaps around implementation are enormous. There is so much work to be done. How do we implement sustainable collaborative care models across diverse obstetric care settings? How do we support postpartum referrals and engagement beyond that postpartum visit? How do we keep people engaged? Are there opportunities to leverage digital health? Can other professionals, doulas, peer navigators, service care managers, and how do we adapt that role or that training? Could collaborative care be used for implementation of prevention services, like Dr. Yonkers told us on the first day about? And if so, how do we identify those at most risk? And then what's the best way to educate obstetric clinicians, right? We can have this system, but we really need to educate our obstetric clinicians on evidence-based mental health care that's required within the collaborative care model. Next slide. So my key recommendations are three, each quite complex. Conduct pragmatic clinical trials to quantitate the benefits of the collaborative care model in the perinatal setting on mental and somatic health outcomes, as well as health equity outcomes. Conduct implementation trials to inform what is the essential core of the collaborative care model or implementation strategies, and what are the adaptable periphery so we can optimize evidence-based dissemination. And then finally, convening a practice-based research network to ensure that perinatal mental health research is meeting the needs of care that's provided on the ground. So I look forward to the question and answer. Thank you so much for your time.
Thank you so much, Dr. Miller. Great to hear your presentation, and really compliments what we heard from other speakers on day one. So thank you very much. Okay, we will now move on to Dr. Lauren Osborne, who will be presenting on perinatal mental health, the knowledge gap. Thank you, Dr. Osborne.
Hi, I'm just trying to start my video. It's a brand new computer and I'm having a little trouble putting it on. second.
Are you using a Mac or a PC?
It's a Mac. Oh, I got it.
Great. Good to see you.
Apologies, just had to figure out with WebEx and the new computer. So I am so excited to be here today. Thank you so much for inviting me. And I can't imagine a better group of speakers to be engaged with. I was actually sort of chortling to myself when both Dr. Davis and Dr. Miller were speaking, because both of the things they're talking about are things that I'm also intimately involved in my work and obviously support 100%. I'm Lauren Osborne, and I work as the Vice Chair of Clinical Research in the Department of Obstetrics and Gynecology at Cornell, but I am not an obstetrician. I am a psychiatrist. And so I am in the sort of unique position of bringing the mental health perspective into a department of OBGYN. And I think that the reason I do that is because of the reason that Dr. Miller stated, which is that mental health is maternal health. And I think until we consider it, we're not going to understand adequately how to deal with the range of not only mental but physical health conditions that arise and in the perinatal period and cause the severe maternal morbidity and mortality that we're dealing with, and especially those racial gaps and inequities that we're faced with. But because Dr. Davis talked about community-based approaches and because Dr. Miller talked about collaborative care, I'm going to take a different tack. And I'm not going to present data on either of those things, but rather I'm going to talk about the knowledge gap that we have in perinatal mental health and why it's really important for us to address that in order to be able to deliver better clinical care to patients in this period. You can do the next slide.
Do you want to advance your own slides?
Oh, sure. I don't know how to do that in WebEx. I'm sorry.
Oh, I thought you did. Okay.
Okay.
I'll just grab it back and do it for
Show me
you.
how to, yeah. Sorry.
Here we go.
Great. I'm going to present a little bit of information that is very much the same as what you saw from Dr. Miller, but with a little bit of a slant. So perinatal mood and anxiety disorders are the #1 complication of pregnancy and childbirth. They affect 1 in 7 pregnant and postpartum women. The next slide. And this is a different version of the exact same graph that Dr. Miller showed you, just showing that perinatal treatment cascade, where we know that women with depression in either the antenatal period or the postpartum period are not getting recognized, they're not getting evaluated, they're not getting diagnosed or treated, and when they are treated, the number that actually go into remission is very, very low. Dr. Miller showed you it's about 3% of women with postpartum depression who are treated to remission, and that is just inadequate, and we have to do more. And part of the way we do more is by the kinds of innovative clinical programs that Dr. Davis and Dr. Miller talked about, but part of it also is in improving our own knowledge base. So the next slide. Mental health conditions, as Dr. Miller mentioned, are the #1 cause overall of pregnancy-related death. This is brand new statistics from the CDC, and you can see that this is the #1 cause of pregnancy-related death, and that 84% of those deaths are preventable. So not only does this affect the way both mental and physical health are carried out in the postpartum period, but so much of it is preventable. And so we have to figure out ways of doing this better. The next slide. I'm showing this data, which is specifically related to New York State, because I think it's a really interesting fact about the factors that are associated with pregnancy-related death. Now, this isn't about deaths that are specific to mental health. This is all pregnancy-related deaths in New York State in 2018. But the reason I'm showing it is you can see the arrows here, the red arrows that I have. They are pointing to the factors that are associated with pregnancy-related death on a whole bunch of different levels: the community level, the facility level, patient and family level, the provider level, and the system level. And the red arrows that I've put on the sides show you that the #1 factor in all of these different facets has to do with knowledge. So knowledge is the biggest problem in factors associated with either community-related, patient and family-related, provider-related, or system-related factors that lead to pregnancy-related death. So we have a huge gap in knowledge. Next slide. And along with that gap in knowledge, we have huge barriers to perinatal mental health treatment. The barriers come at all those different points. They come at the community level, at the provider level, at the patient and the system level. And what we find is that patients don't disclose symptoms or seek care, and that we also have unprepared clinicians with limited resources. And so both of those factors work together, along with other community and systems-based factors, to prevent our recognition and treatment of these conditions. I noticed that there was a question in the chat a little while ago about the fact that some women don't want to disclose depression because they're worried that it'll have negative effect on their children, that their children might get taken away. And that's a huge problem that has to do with lack of knowledge, right? Next slide. So I'm going to talk today about two forms of knowledge that are lacking. There are many forms that are lacking, but I want to talk particularly about two forms that I think are concrete areas that we can really do something to improve. One is our prediction of illness, who's going to get sick. And the other one is in our training of the frontline providers who are seeing women during the pregnancy and postpartum periods. Next slide. So there are two ways that I think that we can improve our prediction of risk in this period. One way is biomarkers. Now, biomarkers are the holy grail of psychiatric research, right? We have been looking for biomarkers since we started doing psychiatric research, and we have failed miserably in most areas of psychiatric research. We think we find a gene, or we think we find something in the blood that can lead us to a test, and it never seems to pan out. But I think it's different in the perinatal period. And the reason I think it's different in the perinatal period is that pregnancy and postpartum is the one biological time when we can predict with some certainty that a certain number of people are going to become ill, right? We don't have another biological trigger across the life course that will predict that a certain number of people will become ill in the postpartum period. So I actually think that there is more hope for developing a biomarker of postpartum depression than there is for developing a biomarker of just about any other psychiatric illness. And there's some really promising data out there in the literature. I am just showing three examples here. The one on the upper left, the one marked A, is examples from the work of Zach Kaminsky and Jennifer Payne, who found some epigenetic biomarkers associated with the development of postpartum depression that were about 80% accurate. The one right below it is work from the lab of Lena Brunden, who's found a biomarker that has to do with inflammatory markers and markers of the kynurenine cascade that together, again, give us about 80% accuracy in their prediction of postpartum depression. And the one on the right is work from my own group where we showed that extracellular vesicle mRNA communication was vastly different in pregnancy for euthymic women who went on to develop postpartum depression. All of these things are potential, and there are many other things out there that are potential for biomarkers that can help us predict illness, but it's a very slow path to get them out to market and to get the research done to replicate them enough times that we can actually be sure that they're real. Next slide, please. The other way that we can think about doing prediction, though, is not through biomarkers, but through data. So we can leverage technology to predict things like postpartum depression using machine learning. So there have been studies that have reported that while rates of screening and referrals for mental health care can actually be high when obstetricians recognize a risk, they're very low if the provider doesn't notice symptoms or doesn't notice factors that may be putting the patient at risk. But if we use machine learning by leveraging the EHR, that may assist with raising clinician awareness of postpartum depression and potentially increasing screening and referral rates. Like, what if we had a clinical tool where we could plug in some things, just like we do for heart risk or cholesterol risk, and predict who's going to be likely to develop postpartum depression? Next slide. So this is a tool that some of my colleagues here at Cornell have developed, which is a machine learning tool that puts in a whole bunch of factors from the medical record to predict who is likely to develop postpartum depression. And it produces a heat map like this. And you can see that some of these factors are things that we already know predict postpartum depression, right? Anxiety in pregnancy, mental disorder in pregnancy, taking antidepressants. We know that that means somebody is more likely to develop postpartum depression. But some of the other things on here are things that you wouldn't necessarily pick to go into a model, right? Other antibacterials, people having diarrhea in pregnancy, people having palpitations or abdominal pain. And each one of those things individually might not say this is a risk for postpartum depression. But if you put them together in a machine learning model, you can predict who is going to develop postpartum depression. This particular model that my colleagues have used is about 90% accurate in predicting the development of postpartum depression. Next slide. We also have colleagues who are developing ecological momentary assessment for mental health across pregnancy and postpartum. There are people doing this not just at my institution, but at many. And the goal of these is to capture fine-grained trajectories of symptoms over pregnancy. So you can have a tool for earlier symptom detection and also a screening tool to further our study of the mechanisms of postpartum depression or perinatal mood and anxiety disorders. This involves active symptom reporting from participants. So it's not just mining the EHR, it's having the patients report daily on symptoms that they're experiencing and doing longitudinal tracking during and after pregnancy. Since the vast majority of patients, even from low income groups, will have some kind of device that they can use to track, developing things like this and using them with patients who are at risk across pregnancy and postpartum may allow us to capture people who are at risk a little bit earlier and may allow us to identify those people and get them into care, get them into treatment a little bit faster. The next slide. And this is just what one of these tools looks like over the course of a day. So you have a symptom scale. The dark bars are where they're having lots and lots of symptoms, and the lighter bars are where they're having none. And you can see that the symptoms that they're reporting are not just mental health symptoms, but physical health symptoms as well. And that can help us to track who is becoming ill or who is at risk of becoming ill. Next slide. So the other part of knowledge, I'm switching gears now away from the prediction gap to talk about the training gap. So we have an enormous training gap in perinatal mental health. We have about equal numbers of psychiatrists and obstetricians in this country, but people who are reproductive psychiatrists who are specialized in the treatment of perinatal mood and anxiety disorders, we have far fewer. I picked the number about 500. Of course, nobody's really tracking it because it's not a real subspecialty, but that's about the number of people who turn up to the annual conference in perinatal mental health. And so you can see that the number of people who are specially trained in this field is much, much smaller than the training of generalists. Next slide. In psychiatry residency training, there is no requirement to learn anything about reproductive psychiatry. These are what the ACGME requires psychiatrists to learn. And you can see that, ironically, people are required in child and adolescent psychiatry training, the 2 months that they have during general adult training, to learn about male and female children. But that same requirement is not there for adults. So no requirement at all for the knowledge of reproductive psychiatry. Next slide. And we know from surveys that we've done of psychiatry residency training directors that there are both positive and negative attitudes toward training and a significant number of barriers to training. So what we see on the left here is from a survey I did where we asked residency training directors if they thought it was important to teach reproductive psychiatry. And the bar all the way on the left was the number of people. It's about 40% of training directors feel that it's important, about everybody should be competent in reproductive psychiatry. But a larger number, about 50%, said, well, it's kind of important, but it's not as important as other areas of psychiatry. And then a smaller number felt that it should be only for interested residents. So the majority think it's kind of important, but not everybody thinks it's essential. And when we ask about the barriers, like why aren't you teaching it? Most of them said, well, it's not a requirement. The ACGME doesn't require us to teach it, so why should we bother to teach it? Or we don't have time. We have other things that we're teaching instead. And a lot of people also said they had no qualified faculty to teach this because there aren't enough specialists in this area. Next slide. Similarly, in obstetrics and gynecology, while there is a requirement that obstetrics and gynecology residents learn something about mental health, there are multiple competencies in mental health, including obtaining a mental health history, recognition and management of the psychological consequences of gynecologic concerns. There isn't actually any specific language about how to operationalize that. Like, how are we supposed to be learning that? How are we supposed to be incorporating that into obstetrics and gynecology education? The next slide. And this is an article that was recently published about barriers to education. So what do people feel comfortable with and what do people not feel comfortable with on the obstetric level in managing and providing resources for these kinds of patients? And what this study found was that all resident physicians felt that their training was either minimal or suboptimal. So 60% said minimal and 40% said suboptimal. And 95% of the people who responded were unsatisfied with the amount of training that they had received so far. 100% of them said that they'd prefer to refer patients to mental health specialists. They're not at all comfortable with dealing with these issues. The next slide. And so there are a few tools out there that are trying to address this gap. This is a program that I run called the National Curriculum in Reproductive Psychiatry. It was designed initially for psychiatry residents. It's a free program available on the web that we hope residency programs will use to train residents in reproductive psychiatry, but it's also freely available for anybody else. The next slide. And when we piloted this program in residency programs, this curriculum, we found that it had a substantial effect on both attitudes and on knowledge. So you see in the red and blue bars here, we have a knowledge test that we administer before and after administration of the curriculum. You can see that residents' knowledge went up substantially. And then on the right, we have their feelings of preparedness. How prepared are you to treat women with perinatal mood and anxiety disorders? And you can see that in the gray bars beforehand, they felt not at all prepared. And in the black bars, which is after the curriculum, they felt much better prepared. Next slide. There's many other educational resources out there that we need to encourage and adopt. This is one that comes from Nancy Byatt and her group doing Lifeline for Moms, where they've made some e-modules partnering with the American College of Obstetricians and Gynecologists to provide training in detection, assessment, and treatment of perinatal mental health disorders, and that's going to be available on the ACOG website. The next slide. So just to summarize what I've talked about, which is this knowledge gap that we really need to address in perinatal mental health, only 3% of individuals with postpartum depression are treated to remission, so we have got to do better. We know that the mental health conditions are the #1 cause of pregnancy-related gaps, but we have vital gaps in knowledge, both in our ability to predict risk and in our training of people who see women in pregnancy and postpartum who don't know what to look for. Next slide. And what do we need to do to make this better? Well, I think we need specific funding to fast-track biomarker development and to speed that path to clinical tests. There are many potential biomarkers out there that have good possibility, but the path toward getting them to development is really slow. We need to really improve the EHR data surrounding social determinants of health and mental health diagnoses. I showed you those big data tools. They're really exciting that we can use the EHR to predict postpartum depression. But the problem with that is that what you put into the EHR has to be accurate. And at least in most of the systems that I've worked in, people's willingness or ability to accurately record social determinants of health or mental health diagnoses is poor. Clinicians often feel like it's a stigma to put a mental health diagnosis in a patient's chart. So if we don't have accurate data going in, we won't get accurate data going out. We need to make training in reproductive mental health an ACGME required element of residency training in psychiatry and OBGYN. It's not going to happen unless it's required. And we also need to consider rudimentary training in reproductive mental health for other specialties, not just psychiatry and OB-GYN, but family medicine, internal medicine, and pediatrics. You know, when I renew my New York State medical license, I have to take a 1-hour training in opioid prescribing, even though I almost never prescribe opioids. I think providers who are coming in contact with pregnant and postpartum women should have to learn something about perinatal mental health. And that is all I have.
Thank you so much, Dr. Dr. Osborne, and sorry to rush you.
That's okay.
Okay, we will now, and actually I meant to say there are a couple of questions for you in the chat if you have a minute to take a look.
Sure.
Okay, so we will now hear from Dr. Matt Hoffman, and he will be speaking on the impact of postpartum blood pressure monitoring and telehealth among birthing people with hypertensive disorders of pregnancy. Thank you, Dr. Hoffman.
Thank you very much. Honored to be here. I'm glad NIH has taken such an interest in this subject and very much feel privileged to be following Dr. Davis, Dr. Miller, and Dr. Osborne, as a lot of the themes that I think you're going to hear the same, the importance of cardiovascular health, the ways of thinking differently and thinking about using teams, and then also thinking about novel tools. My talk is going to be specifically talking about telehealth and talking about hypertensive disorders of pregnancy. And I think Dr. Steele in his systematic review has sort of put forth the overview. My goal is to sort of add depth and breadth to some of those conversations and talk about what I think is promising, but also a need for more research and some thoughts about where that research may need to go. Next slide. So just as required, my disclosure statement, I have nothing to disclose at this time, but I have the next slide. So I'd like to frame this talk really in three parts. First, to talk a little bit about the timing and causes of postpartum mortality, and also to talk a little bit about readmission for hypertensive disorders, which is at least on the pathway to mortality. And then from there, we'll talk about two specific epochs, talking about the time from hospital discharge to postpartum, which is where we have the most data. I'll talk about some of the studies that have evidence supporting remote patient monitoring, talk about the role of predictive analytics, which is in its infancy here, talk about what is we know about in terms of treatment strategies, and from there we'll move on to the second part, which is to really talk what happens beyond the immediate postpartum to 1 year delivery. And I think we have increasingly opportunities as Medicaid has been expanded to help treating birthing persons within the first year. And woven into all of this will really be the discussion about disparities, and what I hope is at least a promising opportunity to decrease disparities and improve care for all birthing parents. Next slide. I think this is an important part to begin, and again, to sort of focus the work a little bit more. This comes from the Centers for Disease Control. It looks at maternal mortality from 2011 to 2015 and really purveys two important thoughts. One of which is in fact the majority, 52% of deaths happen after the day of delivery. And most of this actually lies outside of the time of hospitalization, which is typically 2 to 4 days, depending upon whether it's a vaginal delivery or a cesarean delivery. Other important part of this article is it looked at the causes of death. I mean, if we're going to solve this problem, we need to understand not just when they occur, but why they occur. When you look at them, and again, there's some overlap in some of these categories, about 2/3 are related to hypertension or at least associated with it. So stroke, it's not uncommon to find that the leading cause of stroke is hypertension, and there are other conditions such as other cardiac conditions and cardiomyopathy that may be worsened by being hypertensive. Next slide. It's also important to recognize the physiology of pregnancy. We unfortunately think that pregnancy ends when the placenta separates from the mother, but the reality is the effects of pregnancy continue much beyond that. If we look at postpartum readmission, which is a marker of obviously morbidity, and we look at things like HCUP data, we know that in fact the second leading cause for readmission is related to cardiac or circulatory conditions, with hypertension being the most common. This is really a reflection of the fact that blood pressure, rather than going down immediately, continues to increase typically through about day 8 to 10 after delivery. What you see on the right side on the graph is a study where they did remote patient monitoring of women with preeclampsia. And what you see is, in fact, blood pressure, particularly diastolic blood pressure in the bottom graph, continues to go up on this during this time period. This is exacerbated by women who have a BMI over 35, which are the yellow and the green lines. And again, there probably is some level of racial disparity as women who identify as African American seem to run a higher mean blood pressure to those who don't. Just to extend it beyond that, although obstetricians often talk about preeclampsia, what we really fear is eclampsia. And in fact, about half, 45.8% of eclamptic cases now occur not around the time of birth, but actually occur after hospital discharge, with the majority, 81%, occurring within 1 week of discharge and 14% within the second week. And what this suggests, again, is that this is a critical time for us to be in contact with mothers to control their blood pressures from that perspective. I'll also call again out there is a profound disparity amongst women who declare themselves to be Black or Hispanic and are much more likely, almost threefold more likely, to get readmitted for hypertensive causes. Next slide. So I think a revolution started a number of years ago, and I'd like to give credit for Dr. Hirschberg from the University of Pennsylvania, who, as a fellow, initiated the concept of remote patient monitoring that's led to a lot of interest in this field. This was a study that approached 305 birthing persons who had the diagnosis of preeclampsia or hypertensive disorders of pregnancy. Just to note that she approached 305 women. Only 5 of those women, or a little under 2%, in fact, didn't have access to either a cell phone or the ability to have text. So though the digital divide needs to be part of the discussion, it's important to recognize that at least for many women that this is an option. The remainder of the women who didn't participate in the trial either declined participation or had language issues. Amongst the 206 women that she randomized, 103 of the group, she did one of two things. She either sent them a daily symptom monitor, which is sort of shown on the right, and asked them on their blood pressure, or asked them to return to the office from that perspective. These women were given a blood pressure cuff. And what you can see, and I just like to highlight this number, 92% of the women who had the RPM, remote patient monitoring, in fact, submitted a blood pressure versus only 43% of the women, in fact, who had to come back to the office were able to do this. And this was highly statistically significant. Of note, amongst women who received RPM, 0 were readmitted versus usual care. This was non-significant, but an interesting finding. Next slide. Dr. Hirschberger and group went on to look at the question about disparities in terms of ascertainment. And this is displayed on the right-hand graph. What you look at in the first 2 bars is patients who received usual care. And what you see is a profound disparity amongst parents who define themselves as either Black and non-Black, with non-Black parents, 70% being able to return for a visit versus only 1 in 3 who define themselves as Black. When you move over to the right-hand column, when you give people the tools to be successful, meaning an app and a blood pressure cuff, in fact, the disparity disappears entirely. Of interest in this particular study is they show no changes in terms of medication from that perspective. Nonetheless, this is intriguing data. That group went on to look at their success with a larger group of women, a total of 333. And again, what you see is about 95% of women are able to submit at least 1 blood pressure, meeting the current recommendation put forward by the American College of at least getting 1 blood pressure following discharge within the subsequent 5 to 10 days. Next slide. So one of the questions is what works at the University of Pennsylvania, does it work at other sites? Just to say that there has been other groups that have looked at this. This is a publication that was done in 2021. And what they looked at is 200 birthing persons at 3 distinct sites, the University of Pennsylvania, University of North Carolina, Chapel Hill, and Northwestern. And again, what you see is this very high rate of blood pressure ascertainment, 97% within 10 days. In this particular study, 16% were started on an oral antihypertensive medication that they were not on at the time of discharge. A total of 5% were readmitted. Not only is it important to recognize that it's successful in getting blood pressure, this group surveyed the participants, and 93% of them gave a positive review of the process. Next slide. One question that comes up is in fact, what about beyond the first 2 weeks? And again, what we see here is a study from the University of Pittsburgh, who's rolled out a very similar program from that standpoint. This included 409 birthing persons who had hypertensive disorders of pregnancy. And what you see is over time is you actually do see a decrement in the number of blood pressures that are given. But just to point out that about 83% of women continue to provide blood pressures up through 3 weeks of time. And about 42% had either a titration or initiation of new medications during that time period. And again, you see very high levels of satisfaction at 94%. Next slide. Just to finish out a little bit more of the racial disparity story, this was a study that looked at the onset of COVID. This comes from the University of Chicago, where they pivoted from the traditional approach of asking patients to return to their offices for a blood pressure versus, again, giving patients an app and a blood pressure cuff. And what you see is that there was no significant change in the non-Hispanic white population. But when you look at the non-Hispanic Black population, there was a significant increase from a compliance rate of 48.5% to 76.3%. And what had been a racial disparity, in fact, disappears. Next slide. So it's important to think about compliance and ascertainment of blood pressure. What's important is also to look at the longer downstream effects and can we really meaningfully change outcomes in terms of at least readmission, which is a reasonable proximal marker for success. This is a case control study that came out of the University of Wisconsin. They looked at a number of women who were initiated telehealth and looking at routine care prior to that. And not surprisingly, what you see again is a marked increase in blood pressure ascertainment, this time from 60% to 94%. But what was interesting is they were able to note a significant reduction in readmission with an odds ratio of 0.13. And not surprisingly, that was also accompanied by increased use of medications amongst those mothers, meaning that they were using that data in a very real way to go ahead and treat mothers early, rescue them early before they develop the complications of hypertensive crises. Next slide. This is unpublished data. This comes from my center. Just to state that this is a quality initiative program, I think it helps to illustrate 2 points, one of which is there's also an opportunity to go wrong with remote patient monitoring. So when we started our process, we had a baseline readmission rate for hypertensive crisis of about 1.2%. We recognized that we had about a twofold disparity rate, meaning amongst the mothers who were readmitted, 61% were African American, versus our birthing population, it's about 30%. We initiated blood pressure monitoring in a very similar way as Dr. Hirschberg had done. And we looked at our data following the first 269 women. Very similar to other groups, we had compliance or ascertainment rates at about 90% with one blood pressure and 70%, 10 out of 10 days. And we very nicely managed to statistically increase our rate of readmission by twofold. And this brings up the question about care standardization and optimal treatment. We subsequently put a protocol together, narrowed the choices of medications, made intentional decisions about how patients were to be treated and treated early. We've now enrolled over 2,400 women, and our readmission rate has gone from a baseline of 1.2% down to 0.54%. And what is equally important to us is, in fact, would have been a 2-to-1 racial disparity. In fact, now our readmission rate amongst our African American parents is consistent with our delivery population. We've now extended this to 42 days with the goal of transitioning to primary care with a significant cost savings to the system. Next slide. So this sort of brings up the question of optimal management. Dr. Steele mentioned this study before. What is the optimal treatment? Again, turning to the group at Penn, this was a prospective randomized trial that they conducted looking at Lasix. Biologically, this makes sense if you remember my earlier discussion points about how fluid from the pregnancy re-enters and then, in fact, hypertensive crisis begins to show up about day 7, day 8. They randomized birthing persons with hypertensive disorders to either Lasix or furosemide for 5 days versus placebo. And what they saw was a very significant resolution time to being normotensive to 8.5 versus 10 days, and a 60% reduction in elevated blood pressure by day 7 with an adjusted risk ratio of 60%, suggesting that Lasix may be at least part of the answer. Next slide. Additionally, there's some additional data from HCUP data, which looked at the 2 most common medications that we as obstetricians use, labetalol versus nifedipine. This was a study of almost 1.5 million women, of whom about 14,000 were on labetalol and about 1,300 were on nifedipine. What was interesting, labetalol, though being more the common medication, had a readmission rate of about 1.5. In more severe hypertensive episodes of 1.63. Again, this is not a randomized.
James, I think we've lost his audio.
apologize. I'm not seeing the next slide.
Yep, we lost you for a little bit. I'll go ahead now. Go ahead.
Thank you. Apologize. The other point that I want to make is really twofold. One of which is we know that, in fact, not all women who are readmitted or suffer preeclampsia are diagnosed at the time of their birthing hospitalization. The top study that I'm quoting there, 40% of birthing persons readmitted for hypertension, in fact, don't have hypertensive disorders at their primary admission. And that we need to think about different ways to think about predicting those folks who will be readmitted. This is, again, drawing from Dr. Osborne, is some work that we did using machine learning. We did a derivation cohort and a validation cohort and isolated 31 factors, a number of which very similar to what she found, we wouldn't have guessed were in fact predictive of readmission from that perspective. And I know there are a number of other groups that are looking at this, but we need to have more of these studies that corroborate the same outcomes and findings. Next study, or next slide. Finally, when we get to the question, and the equally important question is, what about beyond 6 weeks? We very narrowly have looked at the immediate postpartum period. We have lots of information suggesting that preeclampsia hypertensive disorders really leads to chronic medical conditions, particularly hypertension, and ultimately can actually be traced to cardiovascular death and other complications from cardiovascular disease. So probably multiple risk factors. And again, we know very little about this from that perspective. Amongst birthing persons, about half of them with preeclampsia will remain hypertensive following the immediate postpartum. And unfortunately, only half of that group, or 24.3%, are in fact on meds. There is no data that I could find looking at remote patient monitoring to see if we can improve those outcomes. I will say that, and you'll see below in the diagram, that there has been some work in the adult world, and this does seem to be a promising venue, but very little work done on remote patient monitoring beyond the immediate postpartum period. Next slide. So in summary, what I hope I've left you with is that hypertension postpartum is a significant contributor to mortality and readmission that disproportionately affects minorities and those with low socioeconomic status. Remote patient monitoring is well accepted by birthing persons and does seem to consistently result in higher blood pressure attainment and seems to reduce disparities, at least in attainment in blood pressure, again, with very good compliance rates in the 90s. Remote patient monitoring appears to reduce disparities, at least in readmission, though the data is very limited to a few trials. And that, in fact, we really don't know what the optimal treatment, and there's significant opportunities to better define that. Additionally, I think it's important to recognize that a significant number of birthing persons at risk for hypertension readmission are not identified through just simply looking at the preeclamptic population that leaves our hospital, and that we need to invest further in understanding and developing models from that perspective. And virtually no work has been done beyond the 6-week time period, even though we know it affects people's life courses very significantly. And if I could get my last slide. So some key recommendations. Again, encouraging studies of remote patient monitoring focused on the important outcomes of readmission and mortality, and really thinking about optimal treatment, very similar to the recommendations by Dr. Steele. And again, thinking about it, recognizing we have a highly digitally engaged population, what is the role of remote patient monitoring between 6 months and a year? And then finally, I'll just say there's a proliferation of people looking at remote patient monitoring for other conditions such as lactation, postpartum depression. There's a very entrepreneurial group who are looking at this, but how do these things work in concert together from that perspective? And as part of this, there are a number of apps that have been developed in understanding whether or not they conform to industry standards. The FDA has begun to regulate this space. The Europeans are using a construct called ORCA to make sure that these things are helpful, useful, and promote privacy. Finally, in my last two recommendations, data lakes are really important, getting big data, being able to understand the impact of adoption of these technologies is really helpful. There's a number of efforts to develop common data models, something called OMOP and BCORNet. This has been very active in the adult medicine community, but unfortunately not as robust in obstetrics. And there's a significant opportunity. Finally, just to point out, much of what I've proposed has been work done in universities supported by grants. Understanding payment policies and remote patient monitoring is an opportunity to better understand and make sure that this is extended to all. And with that, I will conclude my talk. Just to point on the right is the PubMed number of papers that have happened since 2018. And you can see there are a lot of folks who are interested in this subject.
Wonderful. Thank you, Dr. Hoffman. Great presentation. Let's bring everyone back now for this session, for a quick discussion session, starting with Dr. Davis. And Dr. Hoffman, a number of points and questions for you in the chat. I know this discussion session is going to be short, so you might want to try and respond to them there if you can. And I will turn over to Dr. Davis.
So the outcome related to labetalol versus nifedipine was based upon
actually
from that
Dr. Hoffman, I'm so sorry to interrupt you. Let's turn it over to Dr. Davidson for her to start the discussion session. She has a few I know she wants to highlight, and then maybe you could answer them by writing them in the chat.
Okay, so if I could have the members join us by turning on the camera. I'm going to ask the independent panel members if they have any questions for any of these members. While you're formulating your questions or seeing if you have any, I've got some specific questions out of the chat for Dr. Davis. Many families refuse the home visiting services. Please share recommendations for opening the door for them so they might become willing to accept the HIV services.
Yeah, so a couple of thoughts. So one is, using the community health workers from, that are from the community help goes a long way in helping establishing that trust. And so we found that linking them up, like in our program at the time of delivery, making those introductions before they leave the hospital is one way, so that they know once they are discharged, representative from the Healthy Start organization will be following up with them. So we try to make those connections prior to them leaving the hospital, so that when they do get contacted afterwards, it's more of a warm handoff. The other thing that is helpful, what we've seen post-COVID is there have been concerns of people having people in their home, obviously around this time, and the concerns of COVID and other illnesses. One thing that can help bridge this is using the telehealth and video conferencing technology to have those initial kind of conversations, establish trust, and then once comfortable, have the worker visit the patient in the home. So, a variety of those things can really go a long way with helping to establish that trust and getting them to accept.
Wonderful. Thank you so much. I know Pamela Reese, one of the independent panel members, has a question for Dr. Miller.
Yes, Dr. Miller. Thank you for your excellent presentation. I do have one question. It was on slide 14 where you talk about the pre and post COMPASS depression treatment. It appears that while Black persons had a significant increase in being treated, it looks like the white persons went down just a little bit. Can you explain that?
Yeah, so those differences were not statistically significant, and I think that's just noise in the data, to be perfectly honest.
Okay, thank you.
Yeah.
Okay, I've got a question for Dr. Osborne. Are there any mental health screening questions or issues that we could learn from this training that could be added to existing social determinants of health screenings that are carried out in OBGYN departments?
Well, I think that's a great question. That assumes that social determinants of health screening are adequately carried out in OBGYN departments, which I'm not so sure is actually the case. But I think that there absolutely are things that we could add. A lot of people use the 2-question version of the PHQ, the Patient Health Questionnaire, which is just 2 questions that you could add in about depression. But I also think we're reaching the point where we can start to factor in some of these other things that are risk factors. A person may not have depression now, but may be at risk because of social determinants or because of some of those other things that machine learning algorithm I showed is teasing out. And I think there's a real possibility to develop a predictive tool like we have for some physical health concerns that OBGYNs could use. And I know that my OBGYN friends love algorithms and tools. And so I think that's probably a way to go that will really help us advance in that field.
Terrific. And I've got a question for Dr. Hoffman. Are there any clinical studies being conducted that primarily address adolescent and teen populations when it comes to some of the research that you have presented? And you're on mute, sir.
Thank you for the question. I think it's a great question. I think one of the issues is understanding telehealth in different contexts and different groups. Again, that may be a unique population that just given the fact that they are literally digital natives may in fact be more amenable, but we don't have data to support that.
I have a final question for everyone before we take a quick 10-minute break. Any suggestions for interventions for patients with antepartum depression refusing to take medication for fear of how it affects the baby?
I will jump in first to answer that because I actually think it's really related to the knowledge gap that I mentioned. There's a knowledge gap in patients and their family members as well as in clinicians. I think if we improve the knowledge of clinicians, we will have people who are able to combat that fear in patients. The evidence does not support not taking medications in pregnancy. And I think part of the problem is patients have that fear. And if they then encounter a clinician who augments the fear and doesn't combat it, then we have a problem. Most of the patients I've had who have that fear and come to a knowledgeable clinician are eventually talked out of it.
Thank you. And Dr. Terry, I think you have a question for one of the workshop members.
Sure. Thank you for another really excellent session. I was just wanting to know, a couple of the panelists talked about the great potential of AI-based methods for better predictive models, and some of the data was super interesting. I was just wondering if ACOG or people within this field are really focused on the aspect of the debate in data science about whether AI-based algorithms can perpetuate or even increase racial inequities in healthcare. And I was wondering your thoughts on that.
I'm happy to go first and again invite the other comments as well. This clearly needs to be guarded at, but I think there's also an opportunity to get a deeper understanding of context and potentially why there are inequities to look beyond. So we've done some work looking at preterm birth, and again, you're able to draw on things like poverty, renters index, other issues that are actually more predictive than necessarily self-identified race.
Yeah, and I'll add that, yes, I do think that that's an issue, but I think that we need to study that issue, right? We need to look at what are these AI algorithms producing and how does that compare with data that is produced in a different way so that we can better understand where are the problems with the data so that we can improve it.
Okay, and with that, I'd like to once more thank this particular workshop for their help in providing information and future directions to us. We're going to take a 9-minute break and come back at 3:15 p.m.
Welcome back, everyone. We are excited to start the last few sessions of day 3, the last day of the workshop. Let me check in with folks though first and see if either Alicia or Catherine, if you know if Dr. Gibbons is on.
Yes, I see him.
Oh, good. Okay. Okay, great. Well, then I will introduce Dr. Gary Gibbons, and I'm really pleased to do so. Dr. Gibbons is the director of the National Heart, Lung, and Blood Institute, the National Institutes of Health, overseeing the third largest institute at NIH. The institute provides global leadership for research, training, and education programs to promote the prevention and treatment of heart, lung, and blood diseases and enhance the health of all individuals. Before joining NHLBI, Dr. Gibbons served as the founding director of the Cardiovascular Research Institute, was chairperson of the Department of Physiology and professor of physiology and medicine at Morehouse School of Medicine. And we are so pleased to welcome Dr. Gibbons to join us today.
Well, thank you so much for that introduction. It's a real pleasure to be part of this P2P workshop. Clearly, for the National Heart, Lung, and Blood Institute, the issues of women's health, particularly maternal health and maternal morbidity and mortality, is a critical element and high priority in our mission and our portfolio. As this audience of experts is acutely aware, maternal morbidity and mortality rates in the U.S. are disturbingly high, and they're disproportionately affect communities of color. And excuse me, in some ways, pregnancy sort of serves as a stress test, theology analogy, insofar as it often identifies women who are at long-term risk for cardiovascular disease. And clearly, there are a number of predisposing factors, such as obesity, hypertension, that play that predisposing role and have implications for pregnancy outcomes as well, such as peripartum cardiomyopathy, preeclampsia, hemorrhage and emboli, stroke, etc. And so clearly this is a high priority for our institute in collaboration with other institutes and centers at NIH. In addition, it's recognized that these individual risks often occur in context, particularly in those high-risk communities of color, in which we are increasingly recognizing the social determinants of health, as I think alluded to in earlier parts of the workshop, in which place matters and access to healthy, high-quality primary care, lifestyles that promote cardiovascular health, and other stressors that are part of vulnerable communities can play a role in predisposing to maternal morbidity and mortality. And these need to also be part of our understanding as well as our interventions. Toward that end, the NHLBI has engaged in a variety of efforts in women's health, and particularly in understanding women of reproductive age and how we can promote cardiovascular health with multiple initiatives. Certainly in this space, the HLBI has done research that have linked, for example, disorders of sleep. Sleep disordered breathing in particular during pregnancy is a potential driver of some of these comorbidities as well as pregnancy-related outcomes. Moreover, very recently, the NHLBI sponsored the CHAP trial, which, as this audience knows, addressed the treatment of hypertension to a target of 140/90 and demonstrated that in treating hypertension in that way, prevent severe hypertension as well as complications like preeclampsia without compromising fetal growth. And we believe this is a landmark study in this space that hopefully encourages more effective and perhaps more assertive interventions that reduce overall cardiovascular risk in pregnant persons that's more in line with the approaches taken for the general population to prevent sequelae of hypertension. Toward that end, we're excited that that trial rapidly translated into new ACOG guidelines, which we hope is transforming care and contributing to a reduction of maternal morbidity and mortality. It will be of interest and importance to ensure that that is translated into real-world practice, hopefully with implementation, science, dissemination, research as part of a pathway to prevention. Similarly, recognizing the social determinants of health, the NHLBI has launched programs to provide more of a support network around pregnant persons within these most vulnerable communities in our minority maternal health community intervention projects that are more community embedded, in which the implementation science really is enabling and empowering individuals within communities, community-based organizations to support these women in promoting cardiovascular health and maternal health, in particular, often with lifestyle interventions that enhance mental health, social support, dietary interventions, lifestyle changes that, again, can ameliorate outcomes. Similarly, the NHLBI is sponsoring a program called Enrich that uses a home visit approach of educating mother and the family that then influences the childhood development as well. And so forth, promoting not only maternal health, but child health, again, in these vulnerable communities. And so this is a particularly high priority and one in which we hope that some of the outcomes of your work in this workshop will further inform. And so with that, I would like to appreciate your in this space and assure you that this is a high priority for the NHLBI. And we look forward to collaborative efforts across NIH, including our collaborations in the IMPROVE program to advance maternal health. Thank you.
Thank you so much, Dr. Gibbons. We appreciate it for sharing that information, setting a great foundation for the discussions that we're about to have in the last portion of this workshop. So now I'm also so pleased to present Mrs. Heidi House, who is the Illinois representative for Save the Mommies, a nonprofit organization that advocates, educates, and aids in the prevention of heart failure brought on by pregnancy. Ms. House is also a mother, a teacher, and an interior decorator, and a patient advocate. We'll now hear from Mrs. House as she shares her personal experience with peripartum cardiomyopathy.
Hello, can everybody hear me?
We can hear you great and see you. Thank you.
Okay, great. Yeah, I'm doing this for my classroom today. So I'm an 8th grade English teacher. So I just finished a spelling bee, and so now I'm I'm here doing this. Thank you all so much for having me. Dr. Catherine Lindley is my cardiologist, and when she reached out and asked me to speak at this workshop, I was elated. Any opportunity that I'm giving to educate and advocate for other pregnant women, I'm absolutely going to do it because I don't ever want another woman to experience what I did. So I'm just going to kind of start from the beginning. My husband and I faced 4 years of infertility. After 3 rounds of IVF in 15 months, we received the exciting news that we were pregnant with boy-girl twins. It was such an exciting time for our family. I was considered a high-risk pregnancy with my advanced maternal age of 35, but other than my age, I was a healthy 35-year-old. I was a college athlete who had never smoked, ate healthy, and always maintained a healthy weight. Around week 20, I noticed some swelling in my hands and feet. Each week, the swelling became more and more significant. At each appointment, I would ask my physician if she was concerned, and her response was always no. At week 30, the swelling turned into edema and had climbed up both my legs. At this point, I was also having other symptoms such as dizziness, shortness of breath, especially when I laid flat, chest pains, and just overall felt miserable. My physician always told me these were normal end of pregnancy symptoms, especially with a twin pregnancy. So I believed her. And this was my first pregnancy. I wasn't educated or aware. August 23rd, 2017 was the beginning of a nightmare when it should have been the most memorable time. I had been awake all night with sharp pains between my shoulder blades. I could not lie flat, and I had so much pressure and pain on my chest, and my blood pressure also started climbing. I had a scheduled appointment that afternoon, but as miserable as I felt, I decided to go in early. I brought my symptoms to my physician's attention, and after testing, it was determined I was severely preeclamptic. So I was admitted to the hospital, and I was told I would remain there until my babies were delivered. I was 2 days shy of reaching 33 weeks. I was told the goal was to reach week 35, when in reality, the focus should have been on my health, but it unfortunately was not. My blood pressure was quickly climbing, and after starting magnesium, they also decided to start Pitocin. Over the course of the next 5 days, there are many things I do not remember. Unfortunately, some of the memories I do have were not good. Countless times I tried telling the nurse that I could not breathe, and I felt like I was drowning. And each time I would get the same response: "You have to toughen up, labor is difficult." After 15 hours of labor, my physician arrived for the first time to see me, and I asked for a C-section, but she broke my water instead because she assured me things would speed up. Again, all of my symptoms were overlooked. I remember this moment well, and I had never been pregnant before, so I was fighting like hell for my miracle babies. I fought so hard for. I trusted the medical team caring for myself and my babies, that they wouldn't let us down. Little did I know I was struggling, and no one would listen. At 4:15 a.m. on August 25th, I suffered from pulmonary edema. I was intubated, and at 4:23, my daughter, Emery Claire House, was born, and at 4:25 a.m., my son, Ruger Robert House, was born. My babies were rushed to the NICU, and I was taken to ICU. My babies were doing well, but I was very, very sick. My husband had been going back and forth between the NICU and the ICU. Such a struggle for him, as he obviously needed to be in both places at once. Things took a turn for the better, and that afternoon, I was extubated. I wasn't sure exactly what had happened at this point, but I knew I was dying to ask about my babies and see them. My mom and sister had just reassured me that they were both healthy and doing great. However, as they were in the process of extubating me, my husband was called to the NICU as our daughter was in respiratory distress. Upon his arrival, the doctor was performing CPR on her tiny chest, and Emery Claire passed away the same day she was born, without ever feeling her mother's touch. I never got to hold my baby girl and look into her eyes. Unfortunately, my nightmare doesn't end here. The very next day, August 26th, I was moved back to labor and delivery, but I didn't feel any better, and I had the same symptoms I had while in labor. They gave me Ativan to calm me down every time I told them I couldn't breathe. They told me repeatedly I was having a panic attacks from losing my daughter. On August 27th at 5 a.m., I was in cardiac arrest. After several minutes of CPR, I was resuscitated. At this point, my family called a meeting with my care team, and they were told my ejection fraction was 5 to 10%. They also told my family I would need the LVAD if my heart stopped again. So it was decided I would be transferred to Barnes Jewish Hospital in St. Louis, Missouri. Again, my poor husband needed to be in two places at once, as our son was still in the NICU, being 5 weeks premature, weighing 3 pounds, 11 ounces. He made the gut-wrenching decision to travel with me, as I was very, very sick, and he was scared out of his mind. We had family members with our son every day in the NICU. I arrived at Barnes Jewish Hospital very early on August 28th, and that was when Dr. Catherine Lindley took over my care. Dr. Lindley gave my family hope after their initial meeting, and for the first time, my family felt like they could breathe. She officially diagnosed me with peripartum cardiomyopathy. I was extubated on August 29th. Waking up in a different hospital in a different state was terrifying and confusing. Hearing my diagnosis after asking what had happened to me was again terrifying and confusing. Reliving holding my daughter in my arms, and the only memory I had was how cold her face felt against mine, again was terrifying and confusing. Having a nurse ask how my son was doing and afraid to ask my family and fear that something had happened to him as well was both terrifying and confusing. My life has been forever changed after being diagnosed with PPCM. Even though I suffered on a level so deeply most don't comprehend, I am one of the lucky ones. Under Dr. Lindley's care, I fully recovered and have an EF of 65%. Not every woman with my diagnosis can say that. Now that I am educated on this disease, the nurses and physicians let me down. My symptoms were missed and ignored, and this cannot keep happening. And I will spend a lifetime doing what I can to prevent this from happening to another woman.
Thank you so much, Dr. House. Just a difficult story to listen to, and we appreciate you taking the time to do it. You have one more slide. I just wanted to remind you about your representative work for Save the Mommies. I didn't know if you wanted to take a minute to talk about that. You do have about 4 minutes left if you'd like.
Sure. So Dr. Lindley, I believe, at my year appointment told me about this group on Facebook, and there was one of her other patients that also lived in St. Louis, and she and I have become friends. She's also a survivor, and we are both a part of Save the Mommies. I found this, like I said, not long, a few months after everything had happened, and I'm a fighter, and so my initial reaction was, I have to do something about this. I survived this. This has been, just something absolutely awful to go through. And so I have to help other women. I can't let this continue to happen. And when I first joined Save the Mommies, we had about 1,700 women who had joined our group, and now it's like over 5,000. So I am amazed at how many women that this is happening to. I don't really think it's rare. I just think that it's unheard of. I meet nurses all the time who had never even heard of the diagnosis before. So just getting, spreading awareness, social media is a great way to do that. And any opportunity that I'm given to speak, I always do that. I think she showed, I created a pamphlet, and I have taken that to the local hospitals in my area and shared that. And so hopefully they're putting that with all of the other material that is passed out to women who first find out that they're pregnant. So anything I can do to make a difference, I'm definitely going to try.
Well, thank you very much. And certainly joining this workshop and sharing your story with a wide audience is a great way to do that. So thank you for doing it.
Yeah, thanks for having me.
So of course, don't go far. We're going to jump into a roundtable for an hour, and then the discussion session at the end, we'd like to bring you back, Ms. House, if you have time.
Okay, great. Thanks.
Okay, thank you. So with that, I will turn it over to Dr. Dennis McNamara, who's going to share his perspectives before moderating our last roundtable for the workshop. And the roundtable will include Dr. Natalie Bello, Dr. Catherine Lindley, and Dr. Margot Minisian. So before that, I will turn it over to you, Dr. McNamara. Thank you.
Well, first, thank you very much, Ms. House, for sharing that that story. And as she points out, it's not unique in the difficulty women sometimes have at finding someone who will take their symptoms seriously and diagnose them. So I am Dennis McNamara. I'm a heart failure cardiologist at the University of Pittsburgh, where I'm also the director of the Center for Heart Failure Research. And I'm going to be tasked to talk briefly about this very important complication of pregnancy, which may be relatively rare, but remains a major cause of maternal morbidity and mortality. Okay. Oh, no, let me.
I'll advance them for you if you'd like.
Oh, I think I'm getting it there. Okay, there, I think I have it now. Okay, I have no disclosures.
I'm sorry, Dr. McNamara, you're only advancing the slides on your end. So if you want to advance.
No, you can advance. That's fine.
Okay.
I have no disclosures, although I will be talking about off-label use of bromocriptine as a therapy. Next slide. Peripartum cardiomyopathy is a non-ischemic cardiomyopathy presenting late in pregnancy or the first few months postpartum. It occurs in roughly 1 in 2,000 live births is our best estimate, but as Ms. House points out, that may be an underestimate. Most women do recover, but the subset that do not are left with chronic cardiomyopathy and chronic heart failure. And the rate of death or cardiac transplant during the first year postpartum remains unacceptably high at 5 to 10%. Next slide. Now, as I said, women generally present late in pregnancy or the first few months postpartum, but this slide just demonstrates how that generally breaks down. This is from an analysis by the cohort by Dr. Yuri Alkayem, a leader in the field. And the majority of women present with this illness just after delivery, the first week or two after delivery. That doesn't mean it didn't begin early on. We don't know a lot of what goes on late in pregnancy, but there's some trigger at the peripartum period that brings out this illness that we need to find out more about. Next slide. There are risk factors. The risk is like with preeclampsia and the hypertensive disorders of pregnancy, the risk is much higher in African-American women. It may be as 2 to 3 times higher than it is among non-Black women. Increased maternal age and multiparity is a risk factor. Multifetal pregnancies, twin pregnancies are certainly another risk factor. And there is some association with the hypertensive disorders of pregnancy, as in Mrs. House's case. There's some relationship here. They're not always distinct disorders. And the absolute highest risk, and this is a common occurrence, is among women who've had it previously and then recovered and want to have another pregnancy. In a subsequent pregnancy, up to 20%, even with normal LV function, 20% will recur. So their risk is going from 1 in 2,000 to 1 in 5. That being said, it's a strong drive. Women who've recovered, that's a great desire for many women, another pregnancy. Next slide. Now, we studied the clinical and biological predictors of myocardial recovery in a cohort of women in a trial study sponsored by the NHLBI, the Investigations of Pregnancy-Associated Cardiomyopathy, so-called IPAC study. And 100 women were enrolled at 30 centers and followed for 1 year. And what was studied was not only how the heart recovered by serial echoes, but the risk of major events, those being death, transplant, or chronic LVAD. Next slide. Now, this is from the initial report, and this shows the recovery of left ventricular function. So this is the LVEF at entry, 6 months, and 12 months. And on the left side of the slide, that's the non-Black, mostly white subset of the cohort. And on the right side of the slide is the Black women who were in IPAC, which was roughly 30% of the cohort. So Black women are not only at greater risk for the disorder, but they present sicker. They presented with lower ejection fractions, and they just never caught up at 6 to 12 months. So it's not only that their risk is greater, their outcomes are more poor. Many factors are probably responsible for that, but we've got to find out more about them. Next slide. This is also from the initial report from IPAC, and this shows that the outcomes are very different and can be stratified depending upon how severe your disorder is at presentation, what the initial ejection fraction. And as Ms. House, she had a very severe LV dysfunction in her case, and that is women who truly can have trouble with this disorder. And so if we look in the right side of the slide, that's women who presented with initial EF greater than or equal to 30%, and what their final outcomes was. And in the white bars is the percentage of women who had a full recovery, an EF greater than 50%. And that was the majority of women who presented with a relatively moderate LV dysfunction. But if you look on the left side, on those for women who presented with initial ejection fraction less than 30%, the outcomes were much more poor, including only 37% recovered, and an equal number in the black bar, either had severe cardiomyopathy or had an event. And that includes roughly 18 to 18.5% of women who had an event. So you're talking that, and that's those are death or transplant. So you're talking the rate going up from 5 to 10%, looking at women with more severe LV dysfunction to 20%. These are the women that we really need better therapies for. Next slide. Does genetic background, why do women get this disorder? Does genetic background affect the risk of peripartum cardiomyopathy? It certainly appears to. And this slide is from a New England Journal paper by Dr. Wirth. It's actually a study that was organized by Dr. Zolta Rani at University of Pennsylvania in collaboration with Cricket and John Simon. It was really to look at the genetic background of 172 women presenting with peripartum cardiomyopathy. And that included almost all the women in IPAC, as well as an earlier NHLBI study, IMAC, as well as a number of cohorts from Japan, Germany, and Temple and University of Pennsylvania. And what they were looking for was truncation mutations, mutations which actually affect the stop codon, shorten the protein, and sarcomere proteins found to have caused cardiomyopathy in families, to see if we could find these in sporadic cases. They had already shown that you could in non-ischemic myopathy for other reasons, but they looked in peripartum, and indeed they found that 15% of these women, as opposed to roughly less than 1% of the population, had mutations involving sarcomere proteins, including 10% of the women in a single gene, Titin. So genetic background does appear to affect the risk as one factor. However, interesting enough, in future work, they showed it didn't necessarily predict recovery, that women were not necessarily less likely to recovery if they had one of these mutations. Next slide. We have changed the way we think about cardiomyopathy in general and peripartum cardiomyopathy in particular over the last decade. We grew up, I grew up as an investigator thinking about non-ischemic myopathy like peripartum being a problem with the myocyte, being a problem with the heart muscle. But recently investigators, including Dr. Zolta Rani I mentioned before, as well as Denise Hilfaker-Kleiner in Germany, have raised a suggestion that peripartum cardiomyopathy may be in part a vascular disease. And this has led to the consideration of bromocriptine as a therapy. Next slide. So in animal models, in murine models, there's several of them that develop peripartum cardiomyopathy. It appears, and this is from work done and published in Cell 15 years ago by Dr. Hilfaker-Kleiner. It appears that prolactin plays a role in the development of the disorder, or specifically a cleavage product of prolactin, a 16-kilodalton cleavage product, which has adverse effects both on the myocytes as well as the vasculature. And in these models, they found that if you prevent the release of prolactin with a drug widely used for this purpose, bromocriptine, you can actually rescue the phenotype. Next slide. That led to a lot of interest about whether you could use this to improve outcomes for women with peripartum cardiomyopathy. Now, this is from a paper, it's over 10 years old now, from a pilot done by Karen Sleeve in South Africa, where she randomized just 20 women, Black South African women, to either standard therapy alone or standard therapy plus bromocriptine. Since it was a small study, she used a combined adverse endpoint of death, persistent heart failure, or persistent low ejection fraction. And she found that in the blue bars, women on the standard therapy, 80% had an adverse outcome in that small cohort, including 40% of women who died. However, women treated with bromocriptine, only one woman died, and the rest of the women recovered. So it was very positive, even in this small study. That had led to 2 additional studies more recently, one in West Africa, one in Germany, which have also suggested benefit, but have had limitations. And bromocriptine still, the jury is still out, and we still don't know in this country. It's rarely used. Next slide. We feel we need more information, and fortunately, with the help of the NHLBI, we will get that. We have recently initiated the Rebirth trial, which is randomized evaluation of bromocriptine and myocardial recovery therapy, which is an NHLBI funded trial, which will recently initiate, which will randomize 200 women at 50 centers across North America over the next several years to either standard therapy alone or standard therapy plus bromocriptine. We're hopeful that this study will truly determine if bromocriptine can help recovery in women with peripartum cardiomyopathy. Now, the positive potential impact of bromocriptine, which actually inhibits prolactin and prevents breastfeeding, have led to some concern raised by some that perhaps breastfeeding is bad for women with peripartum cardiomyopathy. The jury is still out, and small studies in this country do not show a hazard, but we hope to find out more in Rebirth, as women who are excluded from the trial because they want to breastfeed, you can't breastfeed on bromocriptine, will also be followed, and we'll see, hopefully find out more information. Next slide. Okay. To finish up, what are the knowledge gaps? Well, why do African American women have such a greater risk in poor outcomes? How much of that is disparities of care, socioeconomic factors, institutional racism, or how much of it is it the hypertension, which seems to be important in all these disorders? We need to find out more about socioeconomic and genomic influences on recovery. Is this a vascular disease? This PCM? Can we develop targeted interventions? And finally, I would say subsequent pregnancies and the biology of recurrence. It's interesting that 20% of women recur. Why do 80% not? What is the specific trigger of a single pregnancy? Last slide. What were the key recommendations? Well, it is 1 in 2,000 births. This is not a common disorder, but it remains a major cause of morbidity. We need to develop clinical networks with the appropriate structure to be able to investigate future interventions in peripartum cardiomyopathy. Hopefully, we need continued investigation from existing and growing clinical genetic databases, looking at how genomics may influence outcome and the risk of disease. We need to find out more about barriers to care by talking to women who have had trouble getting care and see what those factors are. And finally, with the network approach, I think we have to do more investigation of the risk of recurrence in subsequent pregnancy, which will also help us to understand in real time what's going on with this disorder. With that, I am done, and I will introduce as the next slide, the next speaker, who I believe will be, this will be part of our roundtable on cardiovascular risks and interventions. As we said, Natalie Bello, Margot, Minasian and Catherine Lindley will participate. And let's go on to the next slide. And hopefully, let's see. Oh, this is me. Next slide. Okay, these are members of our roundtable. And with that, let's get into the first talk by Natalie Bello from Cedars-Sinai. Natalie.
Thanks, Dennis. Hello, everyone. Next slide, please. I'm Natalie Bello. I'm a cardiologist at Cedars-Sinai. And before I dive in, I would just really like to thank the organizers for the invitation to speak today and to the NIH for putting together such a really important and educational workshop. These past 3 days have been really fantastic, and I've learned so much and really appreciate the inclusivity and diversity of all the voices who were at the table. And so I was going to talk a little bit about social determinants of health at the time of first pregnancy and future cardiometabolic health, some opportunities to find, identify, and reduce disparities. And, this is the cardiologist's view of social determinants of health. We've heard a lot from people who can speak a lot more eloquently about this and at a much higher level than my work. Really, people I admire so much in the field, like Dr. Slaughter, AC, Dr. Butler, and others who spoke. But to frame this a little, cardiovascular disease is the leading cause of death in the United States. And similar to our maternal mortality crisis, Black and Indigenous women have higher rates of cardiovascular morbidity and mortality and a risk factor burden for cardiovascular disease compared to women of other races and ethnicities. So I just want to keep that in the back of our mind as I talk about a few things. Next slide, please. Sorry, I'd just like to acknowledge my grant support. It is related to blood pressure measurement in pregnancy and understanding mechanisms of preeclampsia and cardiovascular disease. And I adjudicate endpoints for clinical trials, but have nothing to do with anything I'll talk about today. Next slide, please. So we know up to 80% of cardiovascular disease can be prevented with risk factor modifications like lifestyle interventions, diet, blood pressure control, lipid lowering. And as a cardiologist really interested in reducing cardiovascular disease and making people like myself obsolete, I think pregnancy is a really important window of opportunity that we can really capitalize on to find individuals who are at risk for future heart health problems and intervene early to help reduce their risk factor burden, prevent diseases, and ultimately eliminate disparities as well, as I mentioned. Understanding the social and sociocultural factors that we can hopefully screen for during pregnancy that are most associated with the short-term development of cardiometabolic risk factors is really, I think, a useful first step towards developing interventions to optimize health and prevent disease. So this is just a very high-level overview of some work I led examining the New Mom to Be cohort, which has been funded over the years by both NICHD and NHLBI and other NIH institutes. It originally included 10,038 women who were enrolled at the time of their first pregnancy and are still being followed now about 9 years later. This was an analysis I led looking at individual social determinants of health identified during the time of first pregnancy, and then these individuals who predominantly identify as women's cardiometabolic health 2 to 7 years later. Speaking to some of what we had heard earlier about, these are rather crude social determinants of health. I'm not getting into structural determinants here either, but the takeaway message I wanted was really to say that after adjustment for the measured potential confounders, when we looked at people's risk of developing metabolic syndrome in such a short time period after their first pregnancy, we found, probably not surprisingly, higher income, higher educational attainment at the time of pregnancy were associated with better cardiometabolic health, while being single at the time of your first pregnancy, having government or military insurance, which perhaps is a proxy for losing insurance over time. We need to dig into that a bit more. And having a lower level of health literacy at the time of the new mom to be pregnancy, which was quantified using a validated tool called the REALM SF, were all associated with a heightened risk of developing metabolic syndrome. So again, I want to just use this as an example for opportunities and areas for intervention. Next slide, please. Acknowledging that we really need to, as has been mentioned so many times in the chat and in the prior talks, we really need to meet people where they're at, provide patient and policy level interventions. Some big knowledge gaps, I think, are that pregnancy offers this very unique opportunity in a person's lifespan where we kind of have them as a captive audience. We're seeing, hopefully they're in prenatal care, we're seeing them quite frequently. We can screen for social determinants that we know are associated with higher risk of future cardiovascular risk factors and overt disease. But we do need patient level and policy level interventions to address these risk factors. They can be interventional educations at the patient level, at the provider level. I think hopefully we can get into some discussion during the roundtable about knowledge gaps that exist for clinicians surrounding these areas, as has been discussed a little earlier in the PMADS topic. But we need more social supports. We need access to healthy, affordable food. We need postpartum insurance continuation and Medicaid expansion in all states. These are just a couple of things that I think are really high level, and it's great to see policy people at the table these past few days as well. Next slide, please. So I was asked to keep this very short and just make one key recommendation, and I think I lumped a few in together here, but I would say we really need to develop, test, and then really partner with our colleagues in implementation science to implement cardiometabolic health literacy programs. And based on this brief amount of work I showed, we can identify and target hopefully pregnant postpartum individuals who are and with these lifestyle and literacy programs tailored to a low literacy, lower educational level. We can't be developing things that are inaccessible to individuals. We need, like I said, we need to meet people where they're at and bring them the tools that they need to help them live long, healthy lives and hopefully not need a cardiologist. So thank you. I will turn it over to the next speaker.
Hi, everyone. Can you hear me okay?
Yes,
You're great.
Perfect, thank you. And it's such an honor. I just want to reflect what Dr. Bello had just commented on, to be here with you today. I am here to talk about risk factor considerations for cardiovascular disease, and in particular for those women who've had an adverse pregnancy outcome, and to think about that before, but also throughout their entire life course. Next slide, please. My disclosures are related mostly around my funding. This is all lifetime. Okay. So women in cardiovascular disease has been, thank goodness, finally brought to light. And we are still learning more and more about these risk factors. However, we do know that there are well-established risk factors, as you can see here in the center column. But now we are looking more specifically into sex-specific risk factors. And speaking to the choir here for many of you, this is not as well known amongst the primary care and the cardiovascular community, but it has now been brought into our national guidelines through the American College of Cardiology and the American Heart Association. In 2020, the Women's CVD Commission put together goals to reduce global burden of cardiovascular disease in women by 2030. I've created a QR code here for you to take you to the document. I would like to emphasize here that these under-recognized risk factors are playing a key variable, and it's great to see that this is now being brought to light. Next slide, please. We have risk-enhancing factors that we know play into these traditional risk factors. So going through the continuum, as you see down, inflammation really seems to be the overall driver that these traditional risk factors, both modifiable as well as non-modifiable, can enhance endothelial dysfunction, which results in subclinical atherosclerosis. And I would love to see fibrosis here, which, you know, we just got done hearing about cardiomyopathy and heart failure, which is an important mechanism. Next slide, please. I put this together to really bring an emphasis on the different mechanistic risk targets that we are currently looking at in the cardiovascular community. I put hypertension here on the far right. It's really vascular, but hypertension, I've been told years ago, oh, Margot, everybody has hypertension. Well, yes, and that's the problem. So as we think about a woman and her risk of cardiovascular disease over the life course, this is where we're focusing on, and unfortunately, it's oftentimes too late when they're in their 50s and 60s. My research has led me here to looking at women with adverse pregnancy outcomes, trying to get ahead of it, trying to optimize blood pressure, trying to optimize cholesterol, modifiable risk factors prior to family planning is important. But remember, we need to start to get more creative. I really feel that this is a wonderful charge. So I placed it under my current and future research opportunities to take a look and see what type of precision medicine toolbox we can put together for the younger female patient to be able to do some of this testing ahead of time so that she doesn't have to wait until she's in her 50s and 60s to realize that she's at high risk of heart disease. And in fact, it has already demonstrated it. Next slide. My key recommendations are advanced screening of younger, I didn't mean to write sin, younger populations to predict and prevent individual health risks, trying to optimize their health prior to planned pregnancies when at all possible, to screen women for familial hyperlipidemia, and to measure lipoprotein A when it's appropriate, especially for those who have a strong family history of heart disease. Being able to optimize those risk factors that we do know what to do with. And then lower is truly better, and enhancing blood pressure less than 130 over 80 all the time. I know that there is a lot of discussion around when a woman is pregnant, but when she is not pregnant, that is truly our goal. And we really want to ensure that we help them get there. Thank you very much.
And now we'll have Catherine Lindley. Thank you.
Great, next slide. Thank you for the opportunity to speak today. I have no relevant disclosures. So, I think that this has been really, truly a fantastic symposium over the last several days. One thing that I do think is very important for us to all take away, though, is that really the leading cause of deaths in maternal during pregnancy and in the postpartum period is cardiovascular disease. And in fact, the majority of those deaths actually occur not during pregnancy, but in that postpartum period. In fact, you can see on this slide here on the left that cardiovascular deaths ultimately make up about 1/3 of all deaths within the first 6 weeks after delivery, if you consider cardiovascular and coronary conditions and cardiomyopathy. But I would also consider embolism and hypertensive disorders to be very well situated into cardiovascular conditions as well. And cardiovascular conditions also make up the vast majority of late maternal deaths between 6 months and 1 year after delivery, where cardiomyopathy really makes up the predominant form of deaths that we see in that late period, accounting for about 1/3 of all of those deaths. However, we do continue to see other late deaths related to other cardiovascular and coronary conditions, pulmonary embolism, and hypertensive related disorders. So I think that we really need to think broadly about which patients are at highest risk for these cardiovascular conditions and to think in a very innovative manner about how we can begin to address these from a multifactorial perspective to start to reduce these cardiovascular deaths. Now, there are certain risk factors that we know put patients at higher risk for having cardiovascular morbidity and mortality in the postpartum period. And this is really true across a broad spectrum of cardiovascular conditions. I thought that this table on the right-hand side of the screen nicely summarized this. This is a recent study that was looking at intracranial hemorrhage. And as you can see here in the orange, pre-existing cardiometabolic risk factors such as diabetes put patients at substantially increased risk of postpartum cardiovascular complications, about a 2-fold risk there. In the yellow, you can see that pre-existing behavioral cardiovascular risk factors, such as tobacco use, put patients at substantially increased risk of cardiovascular complications. Very importantly, hypertensive disorders, whether that be chronic hypertension or hypertensive disorders of pregnancy, very much increase the risk of cardiovascular complications related to pregnancy or the postpartum period. As you can see, hypertension itself significantly increases that risk, but if you look in the blue bottom bar at eclampsia or preeclampsia, that very markedly increases the risk of a variety of cardiovascular conditions, including stroke, myocardial infarction, and heart failure. And finally, as you've heard very much throughout the course of this workshop, we know that there are substantial racial disparities in cardiovascular outcomes and that Black and Native American patients are at markedly increased risk for cardiovascular complications. And we actually just recently published a manuscript that identified that really all types of cardiovascular complications occur much more frequently among Black patients. It's not just cardiomyopathy, but also stroke, embolism, arrhythmias, and myocardial infarction as well. Next slide. So I think that the key knowledge gaps here are that the postpartum period is really the highest risk time for cardiovascular complications and maternal mortality, and cardiovascular disease is the leading cause of maternal mortality. We know that both pre-existing and pregnancy-associated cardiovascular risk factors, and in particular hypertension, increase the risk of postpartum cardiovascular death. And we know that Black and Native American patients suffer substantial health disparities regarding pregnancy-associated cardiovascular risk factors and cardiovascular morbidity and mortality. Next slide. So my key recommendations are that multifaceted interventions are urgently needed to improve postpartum cardiovascular health, and particularly in minority patients. This may include increased funding for clinical trials to address postpartum hypertension care, as well as interdisciplinary working groups to develop multi-level solutions to early identification and treatment of patients at risk for postpartum cardiovascular complications. That includes community engagement to improve patient education and access to care, clinician engagement and screening and treatment algorithms, and health policy changes to improve access to care before, during, and after pregnancy. Thank you very much.
Thank you. And I think we'll now move on to the roundtable part of this session and ask all my my colleagues to turn back on their videos and we have, feel free from the audience to put questions in the chat. I see one that we'll try to address a little bit later. But first I want to start off the discussion and perhaps turn first to Dr. Lindley, who you just discussed. You're absolutely right that that blood pressure is very important. It seems to go through a lot of these disorders, and it almost seems like if we did a better job of recognizing and treating blood pressure, that we would go a long way for reducing a lot of the morbidity and mortality we see. Is that possible? What would that look like? How do we get there?
Yeah, I really do believe that something as simple as blood pressure is really a critical key to reducing maternal cardiovascular morbidity and mortality. I think we're beginning to make some progress. For example, Dr. Tita, who I know will be speaking shortly, just published a really fantastic trial looking at chronic blood pressure management during pregnancy. But yeah, there's so much we don't know with regards to what should blood pressure goals be after pregnancy, what should blood pressure goals be for patients with hypertensive disorders of pregnancy, and what is really the optimal method for implementing blood pressure management. There's really a lot coming on board in the last 3 to 5 years with regards to novel models of postpartum clinical care, novel models of remote blood pressure management. And I think we really need to have more resources put into understanding which of these models really work best to deliver care equitably to patients of limited resources in places that are geographically challenging to reach, so that we can make sure that all of our patients can get equitable blood pressure management and really be treated with the ideal drugs and to the ideal goals.
And Natalie, what's your perspective on this?
No, I think Kate said it really well. And, to also just add a little bit of, perspective from the cardiologist viewpoint, we are used to very large clinical trials. We've studied everything, and we get into these minute details of which antiplatelet agent, and we've got 3 different non-inferiority trials of the same thing. And when you turn the lens to pregnancy and hypertensive disorders of pregnancy, and you look at CHAP, which is such a fantastic trial, which I can't remember the exact numbers, but more than 8,000 women, I believe, very diverse patient population. Kudos to Dr. Tita and the team. It's the evidence we need. But it's amazing if you look at the systematic reviews that are out there. This is the biggest trial we've got, but we have so many birthing people delivering every year. Why don't we have more trials? Why don't we have a more robust evidence base? And I think hopefully people are listening. As Kate said, we need more funding for trials like this. And I think it's probably related to money issues. Drug companies don't want to fund trials of, long generic antihypertensive agents, but we need this data. We need head-to-head comparisons looking at, is there a superior drug? Is there a better target for preeclampsia and gestational hypertension? So we've seen ACOG and SMFM have lowered, based on CHAP results, lowered where we should be treating individuals with chronic hypertension. But we don't have the data in preeclampsia and in gestational hypertension. So our treatment targets haven't changed. And I think there's hope, right? There's a lot of great, bright minds at the table, and I think a lot of initiative to get things moving in the right direction. So I think that's my takeaway. We need more trials so we have evidence to implement the best data for our patients.
Absolutely. But I think there's an opportunity there. Hopefully we'll see it. Now, I was interested in Dr. Gibbons' perspective when you talked about pregnancy being almost a stress test, bringing out factors which are going to be important to the woman's long-term cardiovascular health. And And I didn't know, that sometimes that stress test, however, gets lost in the transition, in the postpartum period of where women kind of fall between different teams. And I'm interested, Margot, in your thoughts. And we find these factors that we need to intervene on for long-term health. How do we make sure women don't get lost? Is there a team approach? How do we make sure that we take advantage of the opportunity to give women better care and don't lose them in the postpartum period?
Yes, thank you very much for that great question. And really, to me, it's all about empowering our patients. First and foremost, we heard all throughout the last 3 days, listen. We all need to do a better job listening to when women are telling us about symptoms. In my postpartum heart health program clinic, it's a nurse practitioner driven clinic, and it's a perfect opportunity for us to spend that time. I love the discussions that I've heard about community care. And, we're always looking at ways to extend all these cool bells and whistles, all these different markers, but it has to happen in the community. And, with Dr. Lindley and Dr. Bello here, you've got our national experts here, and it's really disseminating that and getting it into the hands of the women and into the hands of the community. And we heard about doulas. I learned a lot about doulas over the last few days, and nurses play a huge role here. And the experts training the patients and their families and really helping to empower them, I think, is where all of this matters. It doesn't take a cardiologist or a nurse, even for that matter, to learn how to measure blood pressure and then to be vocal about it, to get it treated.
I do think now, in terms of how's the Catherine, how's the team approach work at Vanderbilt? How do you make sure that there is a trade-off, that women are care is continued? And I know there are certain challenges, but what can we do?
Yeah, well, what my experience has been is that we really need to, and I've heard this said throughout the course of the last few days as well, is we really need to break down the silos of care that have developed over the last 20, 30 years of the way we've developed into patient care, and really integrate into a true team and bring care to the patient. It is hard enough to be a new mom who has, absolutely no complications with their pregnancy. But, if you've had a complicated pregnancy, you have a baby in the NICU, and maybe you also have difficulty with childcare and no time off of work, and you don't have transportation, you can't be making it to multiple clinical appointments. What we need to do is think about how to bring the care to the patient in terms of providing that care through telehealth, multidisciplinary clinics that are going to provide both that preventive care and cardiovascular counseling in conjunction with that routine postpartum care and expert hypertension management. And I think bringing all of that into one clean package throughout the course of the third or the fourth trimester, that also has a very clean and clear handoff into long-term preventive care with either a primary care physician or a preventive cardiologist, really has to become the standard of care.
Agreed. I think.
Jump in. I think.
Please.
Another thing that there's been a lot of talk in the chat about empowering our patients. I think we as physicians and nurse practitioners, nurses, PAs, everybody who, midwives who care for these individuals, we also have knowledge gaps that need to be acknowledged, and we need our patients to also advocate for themselves. And so, having patient funded and patient-oriented groups, whether it's Facebook groups or other foundations, the Preeclampsia Foundation comes to mind. They've got a lot of great patient-facing materials out there, because and I hear what's been said about patients who are constantly saying, I have symptoms, and they're not heard. I can only say keep screaming until somebody hears you, and get other people to advocate for you. Because if your physician or provider is not hearing you, find another one. But also, we as physicians and other clinicians need to do better. And I think there are efforts at the national level to improve, as has been mentioned in the mental health and PMAD space. I think we're trying to do a lot at a national level to improve clinician knowledge base around these issues, because there's not a lot of training in medical school, in residencies, in fellowships, even related to these issues, even though they're so common. Ask cardiologists, what's the prevalence of postpartum hypertension, and most people don't even realize it's an issue. So we really need to, speaking to breaking down silos, we need to have more crosstalk between our disciplines and really get the knowledge out there so we can take better care of our patients and know, oh, postpartum preeclampsia is a thing. I learned in medical school, you deliver the placenta, preeclampsia is fixed. There's just so much science and knowledge that we need to really get out there. So
yeah, I agree with all those comments, Natalie. And I just want to add on to a comment from Daisy Lopez in the chat about empowering patients with education and tools. I couldn't agree with that more. And I think there's also, we need to also study how to do that. I think we don't even know when is the best time or the best method of educating our patients. I think anyone who's had a baby knows you go home from the hospital with like trapper keeper full of papers, and some of those may never get read, including like the birth certificate. So, I think we need to be very thoughtful about when and how we educate the patients so that they're actually able to internalize that information and use it for their own sake.
It also strikes me that we definitely need to educate healthcare providers about these issues. I think we also have to work somewhat on our patients, patient advocate, but also sometimes patient trust. It strikes me that there's a lot, particularly among women of color or other groups, not thinking that the health system is what you go to for care, and who don't come to us, and how do we break down that? How do we change that? I think it's a harder problem to fix. Any thoughts?
I think we need more diversity in our workforce so that people can see clinicians that look like them, that, speak the way they speak. We don't need to have, code shifting and other issues that will, alienate some of our patient populations, which, also obviously needs funding. If we want to train more physicians, we need government funding to do that, to increase medical schools, residency programs. But yeah, I hear what you're saying. I think it's really hard when we don't have good community relations. And I think that's something we work on a lot, is being seen as a safe space, and making sure that our patients and anyone in the community who maybe had a baby feels like they can come to us to get better care. Maybe they delivered their baby across town, but they weren't happy, and then they come to us because they've heard that, we are very, as Dr. Manisian knows very well, her clinic is so busy, and people are waiting to get into the postpartum heart health clinic to see a provider, to get the blood pressure treatment they need, to get their risk factors screened. And some of that is just word of mouth, and having that relationship in the community, that people have that trust. How do you build that authentically? I think you have to work a lot on that, and have community partners that you can partner with, so that it's a two-way street. It's not just people from the ivory tower speaking to the community, but community leaders coming in and saying, this is what people need in our group. This is a food desert. How can we get services to these people? We don't have clean air and clean water. How can we make formula for our children if we don't have safe drinking water, water that's free from lead? So yeah, I think I'm rambling a little, but I think, I think we need to partner better.
Yeah, I agree completely, Dr. Bello. And it's that goes all the way through, our patient care, our education, and our research as well. We we need to be bringing in people from the ground level up, all the way up to our clinical trials and leadership in those as well, because, you know, we're not even I think oftentimes we're not even recognizing the gaps in patient enrollment in those trials until after the fact. We're not recognizing that the trials aren't set up in a manner that our patients would want to enroll or be able to enroll. And, you know, we learn so much from just hearing the perspectives of people that look and live and think differently than us, and it does us all good.
No, agreed. Definitely agreed. Now, Dr. Minisan, I think that your clinic may be an example of what we should be doing to make sure that women get appropriate care postpartum. How does it work in terms of your flow? In terms of patients come to your clinic, and what's the long-term strategy?
As Dr. Bello knows, we work really closely together, and I think number one, that's key. You know, we might be the ones seeing the patients, but you've got to have a referral basis because you never kind of know what's going to come through the pike. And probably once a month, I have someone trying to refer me a cardiomyopathy patient, and we're not a cardio-obstetrics program, we're a postpartum heart health program. So first and foremost, you got to surround yourself with some good people that you can refer patients to if you're having a nurse clinic and you know the doors are open. With that being said, though, we're moving currently towards a model that's going to have a 72-hour telemedicine visit when a woman goes home from the medical center. That's what we're working towards. Right now, we're seeing patients about a week postpartum as we're able to. With that being said, I am faculty. I had just hired another doctorate prepared nurse practitioner who's going to be doing, she's coming on as a clinical research scientist. So this is a new type of a role. And in the nurse scientist field, this is a very hot topic of bringing in doctorate prepared nurses into this clinical research work that we're doing so that we can improve the amount of quality improvement studies that we're doing, as well as the clinical trial work. Right now, we're 2/3, 1/3. So I'm going to go run up and see 2 physical patients as soon as I hang up here. But the rest of the time, myself and the other nurse practitioner, we're telemedicine. And then we do refer to preventive cardiologists when we are too full.
Well, that sounds fantastic. Now, question about access to care. I don't know how much of the social how much the effect of social determinants of health are manifest through problems, barriers to access to care. I was noted in our study of peripartum cardiomyopathy that the mean time to presentation to diagnosis was about 14 days in white women and was 42 days in Black women, a time that they were not treated. And as I said, they came in sicker, and it may have been simply the delay. Are there strategies? Are there actionable items we can work on? You know, that could help improve that. Could help prove. I mean, talk about funding. We need a healthcare system that's a little bit more universal. But is there things we can do? Natalie, what are your thoughts?
Yeah, I think, as has been said, we need to listen to our patients. I think, you know, so I'm a tennis fan, and when you think about someone like Serena Williams, who can have a pulmonary embolism, she's experienced one before. She knows what it feels like. She has, and this is not any personal medical information. I've never cared for her. This is all from, you know, the lay press. Tells her doctors she feels like she's having another pulmonary embolism, and it takes 2 days to get diagnosed. If one of the greatest athletes in the history of the world has that problem being heard, I can only imagine what other individuals are experiencing in the community, and what, you know, 42 days, imagine 42 days of feeling like you're drowning and no one's listening to you. And we just need to do better. I wish I had answers. You know, we need to listen to people and take them seriously. People have better things to do than come see us, right? No one wants to go to the doctor. If they're talking to us about a problem, listen, figure out what's going on, and make them better.
And but as you pointed out too, the other issue is, I guess, these are women who are busy with their babies, sometimes with many other children, many other responsibilities, sometimes still working. How do we reach them to make sure that they are, you spoke of getting them to be advocates, the advocates of care. How do we reach them to make them? It's not completely the healthcare system. We need to help our patients, like you said, advocate for themselves. How do we break through the noise that is the life of a young mother?
Yeah, I wish I had answers. And I think some of it's breaking down silos and thinking of different ways to deliver care. I don't have children either, but when I think of what people I know and patients I care for will do, they will, even if they don't have, time off of work, they will make it happen to get their kid, their baby to a vaccine appointment, to get to the pediatrician. And we need to figure out ways to meet people when they're at those visits. We need ways to deliver care in a more comprehensive way. And maybe it's not that people come to us, but as was mentioned in other things, that we've got people who can go in the community. It's community healthcare workers that are funded not just by grants, but in a meaningful way by our, a functional healthcare system. There could be work clinics. We have so little. We can start from scratch and really, think about what a perfect system would be.
Well, I have to add, I think that, I can't leave this part of the conversation without saying that, every single one of us and beyond need to be a part of advocacy as well. 50% of birthing people in this country have their care provided by Medicaid, and there are still many states that do not have Medicaid expansion. And many of those women will then lose their healthcare insurance 6 weeks postpartum. So if you're now an uninsured mother and are presenting with symptoms 7 weeks postpartum, you're not going to come to the hospital unless you literally feel like you're dying, because that's a financial burden that you cannot sustain. There are an increasing number of states that are employing Medicaid extension, which is going to be a very important thing to particularly help, I think, reduce late deaths related to peripartum cardiomyopathy and pulmonary embolism. So I think that, we need to be at our, speaking to our state congressmen. We need to be speaking to our national congressmen about making some of these health policy changes to allow women to financially be able to actually receive the care that they need.
Oh, I couldn't agree more, and I think that's unfortunately is a huge issue, and I am sure a huge contributing factor to our poor statistics. And if you look at what is seen in many of the countries of Europe, some who have the same issues as we do with poverty in terms of, but they have universal health, and they have better outcomes. And I agree that I think that we have to find ways to advocate for that, and to see if we can make a change there. Well, with that, are there any final thoughts to each about where you think we should be going and what you would like to see change or improve in the cardiovascular care and the understanding of cardiovascular risk for women? And I'll start with Margot. Think broadly. What do you think we should do? What would you like to change?
There's so much transformation that needs to take place. If I could start close to home, it would be in California, being able to see Medi-Cal women immediately postpartum. They only get one postpartum visit, to my understanding, and it's never to me. Of course, it's going to be to their OB. And so we're trying to get creative, trying to find what, right now I'm looking for like foundation monies or other ways that I can try and get to see them, but very difficult. So ways to break down barriers to access to the individuals who need us most is most important. And then my second piece and my ultimate soapbox is screening for familial hyperlipidemia in women prior to pregnancy. It's the number 2 driver right behind hypertension for cardiovascular disease, and it's very easy and cheap to look for. And so if we could just start to think about these things in these women sooner, and be thinking of more preventive screening strategies, which I know has been another theme going on throughout the workshop, would be wonderful.
Natalie, any of your thoughts? What you would like to see change?
I was actually just to amplify something in the chat that we didn't have a chance to talk about.
Please go ahead.
There's so Dr. Stu mentions the fact that we don't have paid parental leave either in this country. And when we think about, you know, how could we do better for our patients if they actually had time protected? And, you know, we talk about it a lot for our trainees in medicine because, you know, they are forced to take vacation time or, you know, their elective time to have a child and, you know, recover from childbirth. I think that would be a tremendous step towards, you know, if we had a national paid parental leave for both parents or however many parents are in this family unit, we could really let people focus on their health and wellness and healing and getting the care that they need to be their best selves. So thanks to folks who put that in the chat.
And Catherine, any thoughts on what you would like to see change in the system? Or
Well,
where do you think we should go?
Yeah, there are so many. It's hard to limit it down to one. I think I'm going to have to put myself at two, which one is from a research perspective and one is a policy perspective. From a research perspective, we have to see funding dedicated to postpartum hypertension care if we're really going to move the needle on cardiovascular outcomes. It's a major contributor to healthcare disparities and to cardiovascular death and morbidity. Number two, I think from just a practical policy perspective, we need to see a change in the way postpartum care is reimbursed, because I think until hospital systems are not delivering postpartum care for free, we're not going to see them do what needs to be done, which is to see women frequently and intensively. And that's the right thing to do. But right now, related to the bundled payment systems, I don't think we're going to see that on a massive scale.
No, I agree. We have some challenges. We have a lot of challenges in terms of making the system work a little bit better. With that, I don't know if we have a few minutes remaining. I don't know if there's any other questions in the chat that we had missed and not addressed.
Dr. McNamara, we're just about to jump into a chat or discussion session with the panel chair, so she can cover some then too.
Okay. With that, I think I want to thank my colleagues on the roundtable today for what was a very good discussion of the current state and what we'd like to do in this field. And it was I learned a lot. I hope the audience enjoyed it. With that, I think I will turn it over like a minute earlier to Dr. Davison.
Thank you so much, Dr. McNamara. I'd actually like to open the questions before I even turn it to the panel members to ask you for the one or two changes that you would like to see, given the conversations that we just had.
I share the from a clinical perspective, the perspective that's been said that part of the problem we have is women falling into this gap, whether that's a coverage gap or not, where they're not getting adequate care. And I would love to see a change in the actual coverage of the women of the healthcare. And I think that's the biggest thing, I think, that would help us bridge this gap that exists in terms of maternal morbidity and mortality. From a research perspective, although I work in cardiomyopathy mostly, I think the work and echo what others say about hypertension. And I think if we would just have better strategies for reaching women, for understanding the development of hypertension and for treating it, I think it would go also a long way. So that I look, there have been advances, as was pointed out, there have been great advances in hypertension and pregnancy. So we know it can be done. We just know there's more to be done in the postpartum period.
Right.
Thank you.
Well, thank you all for the roundtable, and I think the conversation amongst yourselves was particularly important because this is a dialogue with so many gaps and so many issues to be addressed. I'd like to open it up for any questions first from the independent panel members. And perhaps while they're formulating some thoughts or questions, I've got some specific questions for some of you individually and some that will be for group conversation. I'll start with Dr. McNamara. Do you happen to know how common cardiomyopathy is for pregnant teens and for Black and Hispanic pregnant teens?
I think the in terms of, you mean peripartum cardiomyopathy?
Yes, yes.
Yes. I would say that the incidence, it mirrors the general. My sense is that for Black teens, it's also more common. I don't think it's more common than the overall rate, but it may be as much as 1 in 1,000 because the rate of live births, because the rate is higher. The 1 in 2,000 is overall. It is higher in women of color, and there's no reason to suspect that will be different for young pregnant women. For Hispanics, I do not think the rate is distinctly different from the overall population. And again, for teens, I think it would still be probably on the order of 1 in 2,000. Now, as pointed out, that may be an underestimation because for about 20 years, we saw the rates or the rates going up in peripartum cardiomyopathy, but a lot of that was recognition. I think people being more aware of the diagnosis and looking for the diagnosis. So it's possible that the overall rate is underestimated with that, as was pointed out by Ms. House, that may be an underestimation.
Right. For Dr. Manessian, what are the recommended strategies for using teen science approach to address knowledge gaps on the under-recognized role of abuse and intimate partner violence in the prevention of cardiovascular diseases among women and pregnant persons?
Yeah, I was contemplating, I saw that in the chat, that question, and I'd really actually love to turn it around. My focus of research is predominantly, I'm a lipid specialist, so I don't feel like I'm appropriately qualified to necessarily talk about it. But what I would say about it is in regards to a team-based approach, we had Dr. Einav Akwart on our panel discussion yesterday. So, having the right team members that you can pull into if you're suspecting that you are with a person who's in an abusive relationship, I feel is key to have the right expertise surrounding. And I often lean in on her to help give me advisement in that regard. I understand that not everybody has an expert clinical psychologist at their fingertips. So with that being said, reaching out to, hotlines, tip lines, having information. I know that there are many centers that will put information in restrooms and in other places where they can have a tip line. I think is important to try and have as many of those resources as possible available to our patients. I hope that helps.
Yes, thank you. For the whole group, there's a question in the chat. Has anyone explored the impact of environmental or dietary microplastics in the inflammatory pathway and their influence on pregnancy, as well as on comorbidities and deleterious outcomes?
I've
I've certainly not personally looked into that. I don't think anyone on this panel is doing specific research on environmental factors, although I do know that there is work going on nationally by some other groups looking at environmental exposures and adverse pregnancy outcomes, including hypertensive disorders of pregnancy. While I don't know that any of us can specifically speak to that, there certainly is work being done in that area.
I was going to say, I don't know about microplastics, but certainly in the realm of BPA and exposures to some of these endocrine modulating agents that we find in our water, I think ubiquitously, unfortunately, there are quite a few studies showing increase even as early as childhood and increases in hypertensive disorders of pregnancy in individuals who were exposed years earlier. So I think it's a really important line of work, and speaking to the need for really longitudinal care and I think a way to incorporate all these exposures and thinking of the exposome and how can we track this and the impact on people's health over the lifespan. It's a great question.
And I concur. I think the issue of environment is very important. I don't know of any specific research into the microplastics, but I think it's a very important issue and one which hopefully environment in general will hear more of in the next few years.
The next question is also for the whole panel. Given the discrepancies in so many of the policies and practices for various time periods postpartum, 6 weeks for OBGYN visits, 12 weeks or less for maternity leave, 40 days or less for insurance coverage, 1 year recommendation for follow-up clinical care. Is there a need for a standardized time frame for the postpartum period in practice and policy?
Well, I think what I would say to that, first of all, is I actually love the current push by ACOG to really think about the first year as being the postpartum period. There is so much that happens during that time period, both physically, but also emotionally and behaviorally and socially, that I think it's a little naive for us to think that in 6 weeks or even 12 weeks that you're back to normal and you can just go to your job and resume normal activities again. I think from a cardiovascular standpoint, and there's still a lot we don't know with regards to, when we should really be optimally screening patients for cardiovascular risk factors, or when we should be optimally instituting cardiometabolic risk factor reduction protocols. And so I think a lot of that really still needs to be studied. So I think, yes, it would be great to standardize it. It should probably be longer rather than shorter with more intensive follow-up.
Agreed. The longer the, oh, please.
No, go ahead. Sorry.
No, I was going to say, I agree that at least a year, and the longer the better. So.
Dr. Terry.
Thank you. And thank you again to this panel for another great session. We started the whole workshop looking at the very sobering trends over time. So not only the really dramatic absolute differences in maternal outcomes in our country compared to other countries, but also the increase over time. And you showed us some interesting data on cardiovascular proportion of those morbidity and mortality. Can you comment on just what's happened in the U.S. over time? Are the cardiovascular outcomes increasing, or what aspects are increasing the most? Is it across the board, or is there a change in cardiovascular events over time? And also, because of the discussion brought up in this panel, particularly with the difference in paid leave policies, I was wondering if the individuals from California can talk a little bit about, since their paid leave policies have been on the books a little longer than some other states, has that resulted in a change in the proportion of cardiovascular events?
Well, I can quickly speak to the national trends, and then I will let the other experts speak to California. So certainly we've seen over the last several decades the proportion of overall maternal mortality steadily rising, including the proportion of cardiovascular deaths, and that's likely related to steadily increasing rates of chronic hypertension, diabetes, and obesity, as well as increasing age of first birth, and also probably some small component of increasing number of adults surviving with congenital heart disease. Although honestly, the vast majority of deaths are related to acquired cardiovascular disease, not congenital cardiovascular disease. What I think is really important to recognize, though, is that it is anticipated we're going to see a sharp rise in this in the next several years related to a recent legal changes in the United States. Following the overturning of Roe versus Wade, it's anticipated that there will be about a 20% increase in overall maternal deaths and about a 30% increase in Black women, as more and more people are unable to access abortion care when they need it. So I think that it's really time for all hands on deck to start to think about scientific and social policies to really address this issue.
Yeah, and then I'd like to elaborate on that. I am very proud that California has both leave for both parents, and I think that that is really fantastic. I would say in cardiology, I'm in postpartum, so I oftentimes miss the brunt of this. The paperwork's already been completed. They're already on their leave. And it is not a common issue that I am hearing about in the early postpartum setting. Where I find difficulty is after 6 months, they're still managing pretty rampant hypertension. I've now got them on 3 antihypertensives, and they're going to try and go back to work. So, I was just dealing with one of my patients who's a police officer, and she's going to go run after, out on the field. And I'm quite frankly worry about her. And being able to stay on our medications and, try and learn how to navigate new family dynamics. So I write her letters and I give her, I extend it for her.
In terms of the increased frequency, it's not clear to me what the reason for the increase in cardiovascular deaths, although certainly as Dr. Lindley pointed out, increasing maternal age and perhaps the increasing metabolic syndrome or an obesity may be contributing factors. I confess I'm very concerned about what will happen again in the time post the Supreme Court decision restricting safe and abortions, because this is certainly a huge issue for women who have recovered. We counsel women all the time that there unfortunately is who have accidental pregnancies, that there is roughly a 20% risk of developing peripartum cardiomyopathy with that subsequent pregnancy, even if they've normalized. It was certainly much higher if they haven't. I hope that it's not quite as severe as has been predicted in terms of the increase, the resulting increase in maternal mortality, but we'll see.
The next question from the audience is a question about the fact that young adolescent girls don't get pap smears anymore, and therefore don't build a regular relationship with the OBGYN. What reason will they have to go to an OBGYN unless it's a problem and it's too late? And if any of the panel members would care to comment on that one.
I agree that, they may not be needing pap smears at this point, but, it's not the job of the OBGYN to counsel the patient on contraception. It's all of our job. We know that the majority of patients seeing a cardiologist have not ever talked to their cardiologist about pregnancy planning or contraception.
I don't know the data for other chronic medical problems, but I suspect that that data is probably similar. And really, we need to consider pregnancy counseling and contraception counseling to be a routine part of care, no matter what subspecialty we're in, because we know that highly effective contraception is a potentially life-saving intervention for our patients with pre-existing cardiovascular disease or cardiovascular risk factors.
I would just add that, I actually just had to look up what the USPSTF is saying about pap smears because I wasn't sure what the cutoff was and didn't realize it was 21 now and not 18. But I think to Kate's point, whether it's physicians of any sort, pediatricians, OBGYNs doing contraceptive counseling, and also just somebody had just put in the chat what I was going to mention, whatever happened to health education in schools? And my sister's a public school teacher, and I know they're under tremendous pressure to do so many things. But, we need to, again, sort of think outside of the box and not just live within our healthcare silos, but think about really public health education and where are the places we can provide this to young individuals so that they feel body positive, feel comfortable talking about their bodies, expressing things to whether it's a physician, a nurse, whoever it is. And maybe that is really going back into the schools, whether it's public libraries. There's so many possibilities, and I realize those institutions are all very overtaxed, but we really need innovative solutions because we're really just not getting the message across.
And I would add to that too, then women need to be able to, and particularly adolescents, need to be able to actually access that contraception once they have been educated and recognize that they want to obtain it. We know that there are many contraception deserts, particularly throughout the Mountain West and the South. And unfortunately, those areas oftentimes match up with areas where there is no access to abortion. And so that is really a setup for an increase in unplanned pregnancies and inability to terminate pregnancies in high-risk patients.
Dr. Braveman, one of the independent panel members, has a question for the panel. We'd love to hear your panel discuss why has the postpartum period been so understudied relative to other periods in life?
Because it impacts women and we don't study things in women as much. No, sorry, only half joking. But when I was interested in pursuing the work that I do and looking at hypertension in pregnancy, and I trained at many different hospitals, it was hard to describe to cardiologists why a cardiologist might want to be interested in hypertensive disorders of pregnancy. I was told women are only pregnant for 9 months, and we're cardiologists, we deal with things later in life. So I think there needs to be sort of a reframing and a realization that the lifespan is important, and we need to, there's so many aspects that have been understudied, and it's a good time to rectify those deficiencies.
I think unfortunately also for a long time, not only the lack of study of postpartum, but even the study of pregnancy has really been baby focused. Our outcomes have been really focused on fetal outcomes and not really focused on maternal outcomes. And we're starting to see a shift in that tide, but we need to make it a really quick shift.
Yeah, I don't have an answer for why it hasn't been understudied, except that I think that that certainly is changing now. I think with the increased awareness of the importance of it to in terms of maternal health and women's health, even long-term health. And I don't have a good answer for why it wasn't being studied before. I kind of came into this game interested in non-ischemic cardiomyopathy and ended up spending so much time with this particular disorder. But that is changing. There's more interest, there's more research. We are learning more every day, and hopefully that will continue.
Absolutely. I think the final question, should there be more dedicated weight management programs postpartum or intrapartum to help mitigate not just the risk of obesity by itself, but also hypertension? What would such a management plan look like?
I'd like to take this on. So I've been in a women's heart center for 18 years. And when you mention the word weight and you mention around individuals who just had a baby, there's a lot of, we talk about stigmas and we talk about, the importance of being able to meet our patients where they are mentally, physically, emotionally. And we really need to be careful, I feel, around this. I understand the absolute importance of weight management. I feel that really promoting those behaviors and talking and educating about those behaviors that help reduce, diabetes, obesity, a lot of it has to do with lifestyle changes, and you have to make sure that a woman is able to hear these things. So sometimes we sprinkle it in, oftentimes we're emailing them and sending them lots of information, and then we go over it and over it and over it in little bits. And that's where I really love telemedicine, because you can spend a little more time, addressing, lifestyle, which, it can't be done in 10 minutes on one visit. And if you mention anything about weight, many women will just shut their ears down and they won't listen to anything that you say. And if they thought that they were supposed to lose 5 pounds before they see you the next time, they'll miss their appointment because there's shaming associated with that. So we just, I feel like we need to be, it's important, but we do need to be thoughtful on how we approach it.
Absolutely. And on that note, I'd like to mention, I've put into the chat that there was a new USPSTF recommendation on healthy weight gain during and post-pregnancy that offers evidence-based recommendations for how to attain that. We'd like to thank this great workshop and panel for the very interesting and invigorating discussion. As you can see, we have on the screen many of the takeaway points that you've made during this, which I think is very compelling. So thank you again, and I'd like to turn it over to Kate to introduce our final speaker.
Thank you, Dr. Davidson. Great roundtable. I feel like it left our independent panel with more questions and answers, but wonderful questions and research gaps. So that was great. Also want to say thank you to Mr. Joe Watkins, our graphic artist, for that illustration. Okay, I would now like to introduce Dr. Tita, who is our closing keynote speaker. Dr. Tita is the University of Alabama at Birmingham Endowed Chair of Global Health, Director of the Institute of Global Health, and the Heersink School of Medicine Associate Dean for Global Health. As Professor of OBGYN and Senior Vice Chair for Research and Innovation, Dr. Tita also leads the Center for Women's Reproductive Health. His background is in maternal fetal medicine, perinatal epidemiology, and international health. And Dr. Tita, welcome. We are so happy to have you.
Terrific. Thank you so much for that introduction, and good evening, everyone. Thank you to everyone, the organizers, panel members, speakers, and audience for what has been an amazing and truly informative workshop. I am going to say I have no relevant conflicts, but really thankfully acknowledge research funding from these groups, including NICHD and NHLBI, as well as the American Heart. Let's begin with this real scenario. 23-year-old G2P1 Black patient, 3 weeks postpartum after a cesarean delivery before 28 weeks due to severe preeclampsia, not taking her 2 blood pressure medications. She took ibuprofen for headaches. She missed her blood pressure check visits 2 weeks ago, had not seen her baby in 3 weeks due to transport problems within 20 miles from the hospital. Her current BP is at 200/110. She's nonchalant about blood pressure medications and adherence, really wants to get back to work, and hopes to visit the baby on the way back home. She was able to get a transportation voucher. So how do we treat this patient and support this patient to avoid a catastrophe? So having lived previously in Cameroon and in the UK, I have been exposed to 3 disparate health systems in terms of access. Early work in Cameroon, shown here, highlighted the lack of use of life-saving interventions due to a simple lack of awareness and the lack of access to materials and supplies to be able to implement these interventions. And as we know and has been alluded to here, this is something that's present here in the US today, especially in some of our underserved settings. I have been fortunate to collaborate with multiple investigators and networks, and we have applied a biomedical lens to key pregnancy and postpartum problems, leading to national policy changes. And I'll go quickly through a number of examples. 1, optimal timing of delivery. So over a third of repeat cesareans were being done primarily conveniently prior to the recommended 39 weeks. And interestingly, this intervention was more accessible, so getting earlier was more accessible to whites than to others. We were able to show that neonatal morbidity was increased with earlier delivery by 50 to 100%. But also relevant to this meeting, in another publication, we were also able to show that maternal morbidity and postpartum hospital stay was also increased with earlier delivery. And this subsequently led to reinforced policies. In this example, simply using subcuticular suture over usual care with staples for cesarean skin closure reduced wound breakdowns that can be really a major impediment to the mother, reduced this by 60%. And this procedure has now become standard of care. In this NICFD-funded multi-center study, adding inexpensive azithromycin to usual antibiotics for cesarean delivery reduced the risk of postpartum infection, a composite shown here, by approximately 50%, and also wound infections that can again be significant for the mother by almost 65%. This translated to reduced costly readmissions on scheduled visits, including ER visits. In a subsequent cost analysis, this was estimated to have cost savings shown here up to $275 million per year in the US. And of note, it took over 20 years from the seminal trial suggesting potential benefit of azithromycin and 1 to 2 years from our trial for new guidelines suggesting the use of azithromycin to be implemented to prevent postpartum complications. That US trial led to a multinational trial of oral azithromycin for vaginal delivery in low and medium income countries, shown here briefly. And this finding should be out within the next 6 months. So this is an example of learning in a local setting and also applying in a global setting. The CHAP trial has already been alluded to by multiple speakers, including Dr. Perez-Table this morning and Dr. Gibbons, funded by NHLBI. So I'm not going to dwell much on this, but just to say that treating non-severe chronic hypertension was associated with this reduction, and only 15 had to be treated to prevent one of the composite primary outcomes, including preeclampsia that was severe. These components have been presented. No safety concern for the baby as previously thought. And then also across a number of hypertensive disorders here, benefits for the mother. Small numbers of very bad outcomes, including maternal death, occurred, but you can see a trend potentially in favor of treatment at the top. So it's already been alluded, ECHO came out with a recommendation and advisory to apply this intervention within days of the publication, and the Society for Maternal Fetal Medicine amazingly came out with a new recommendation the same day as the publication. So really great progress there that included proactive orchestration with policymakers. So back to our patient. Do these studies really fully help this patient? Can we bring the treatment home to the patient? If she had a cardiac complication or a renal complication, would she have multiple visits to meet specialists? Can we use clinical and biological markers to predict and address who will return with a hypertensive complication, severe hypertension, or infection before these patients are actually discharged from the hospital, so we can intervene prior to discharge? So very quickly, I would like to mention the new American Heart Association Health Equity Research Network on Maternal and Infant Disparities, funded this year to the tune of 20 million, with the sites and collaborative sites shown here, as one way by which this problem can be tackled by moving the frontier forward. And also, I believe the upcoming NICHD Maternal Excellence Centers mechanism will also contribute to filling this gap. So the new network emphasizes addressing racism, social determinants, early community and patient engagement, access and quality, translation to policy, and training the next generation. This framework has been addressed, moving beyond the biomedical lens. We also borrowed from the global setting by alluding to the mortal delays and paying attention to this. What are the delays to seeking care, the delays to reaching help, and the delays to receiving adequate help? And it is exciting that there is momentum around what some have coined the fourth delay, meaning taking responsibility and providing resources to overcome maternal mortality, which is why we are here today. The structure is complex, as you can see, including 5 projects, 5 cores of experts to support projects, partnerships with HBCUs and community organizations. But you can see projects here and several cores that interact to optimize the work. So as I close, I would like to I acknowledge the leaders, several of whom have participated in this workshop, and also really extol the multidisciplinary group across multiple institutions, not just those in the network who participate in the course to optimize these studies. So in terms of what recommendations would be and what a summary would be, I think it's important to go beyond the biomedical framework. That remains very important, but take into consideration social determinants of health, engaging the community and the patient, importantly, access across the different ways that have been discussed, including taking care to the patient. Quality care, as we've done with some of the trials, and helping that remains very important, training the workforce, and then specific content areas shown here. This is not exhaustive. Team care, right cadres, mental health as sort of a key focal area that can address multiple issues, protocols and bundles, all types of ways to get to the home, and local and global partnerships. So I'm going to pause here and thank you very much for your attention and for the invitation. Thank you.
Thank you so much, Dr. Tita, for closing us out. We really appreciate it, and a great message to end on. So thank you very much. Well, we made it. We're at the end of day 3. So I just have a couple of thank yous and closing comments that I want to make very briefly. if you could stick with us for just a moment. First, a reminder that everybody today will receive the Day 3 survey, so please fill it out if you have a moment. And I want to take this opportunity to say thank you to our workshop co-sponsors and planning team members from NIH, including Dave Thomas, Pamela Stratton, Yawande Oladende, Patricia Bandettini, Juanita Chin, and Rosalind King. These scientific staff members at NIH have spent countless hours thinking through the current state of the science and planning the workshop with strategy and innovation. Thank you also to our workshop speakers. We had over 35 of them who brought their science to us this week and their keen perspectives. And to each of you participating today, remember that you have an opportunity to comment on the draft panel report, and we'll let all registrants know when it is available. And then it goes without saying, thank you to ODP and WestStat staff who worked tirelessly the past 2 months, and especially this week. You really are a wonderful team to work with. And then lastly, thank you to our workshop and panel chair and all of our panelists. The yeoman's job now sits with the panel to draft the panel report. It is a task, but one we know will yield a report that will be used by numerous federal agencies in the years ahead to develop new programs and funding opportunities that will fill the evidence gaps we've heard about this week. So this effort took a village, and we want to thank all of you. Thank you very much. With that, I will turn it over to Dr. Davidson, I think with a quick note for the panel and any closing comments.
Yes. So I join Kate and everyone at Office of Disease Prevention for thanking the village this took and the 2-year journey you took to ensure that we had many different topics of a comprehensive nature covered. And I want to thank all of the participants for their really eager questions, comments, resources that they contributed in the chat. I think that's a wonderful way for us to end. For all panel members and ODP, we'll be starting the Zoom meeting immediately. So if you can go across to that. And with that, I'd like to close this 3-day workshop. Have a good day, everyone.